So typically these are paroxysmal. Paroxysmal means they're transient or temporary occurrences. They typically will start suddenly and will end suddenly. That's a hallmark of majority of seizures. As a rule, they are more commonly than not, they're typically very brief, but of course they can be prolonged. We all know about status epilepticus. Now the challenge is that the sign and symptom complex or look of the paroxysmal event is very, very variable. We all only talk very often in our residency, especially we talk about GTCs. But GTC, as we all know, is just one seizure type. And so many things can look like a GTC, which are actually not epileptic. And so many epileptic events can look so variable. A single jerk to going blank or having funny, unusual moments or just describing some funny deja vu sort of seizures. So because the look of the seizure is so variable, anyone who comes to you with a so-called first unprovoked seizure, it becomes so very challenging to diagnose whether it was epileptic or non-epileptic. Of course, the seizure mimics very often look very similar to epileptic events, and rare patients have coexisting epileptic and non-epileptic events. So that just adds to our challenges as a clinician. Remember again, and I think this is a point that I'll keep reinforcing through the next 20-25 minutes, that if we think it's epileptic, remember there are many etiologies. Epileptic seizures are just a symptom complex of an underlying brain disease. So having understood this, the next question that comes up is, if a paroxysmal event is because of an abnormal neuronal discharge, would we call all seizures, all epileptic seizures, epileptic? Definitely not. And there is a very important concept of that first paroxysmal event would be an epileptic seizure, but there's a concept of acute symptomatic seizures, and it's very important to differentiate acute symptomatic seizures from unprovoked epileptic seizures. So what are acute symptomatic seizures? They are epileptic. They do occur as a symptom of acute brain dysfunction, but then they are provoked. So this epileptic seizure occurs in the context of some sort of acute brain dysfunction. For example, there is trauma to the brain. There's a stroke. There's a or indirectly, the brain function is affected because of generic problems like a metabolic disturbance. There's hypoglycemia. There's hypotension. There's hypoxia. In young babies, there's hypocalcemia. So all the certain external or internal factors which affect the brain, causing acute brain dysfunction, which can manifest as an epileptic seizure. But these epileptic seizures, remember, are provoked and hence not constitute epilepsy. And it's very important to get this clear. So anytime, again, you see a child with a first paroxysmal event, you think this is epileptic, then the next question you're asking yourself is, was this provoked? i.e. was this an acute symptomatic seizure? And in that case, treating the underlying cause of the brain dysfunction is what is the main treatment and not really long-term anti-seizure medications. But on the other hand, if it's epileptic seizure, then you're going to ask yourself a question. If it's unprovoked, then you're going to ask yourself a question, is this epilepsy? And do I need to treat this with anti-seizure medications? So the approach radically changes. So again, not constitute epilepsy. These seizures do not require long-term anti-seizure medications. Common examples are babies who get admitted to NICU with HIE or hypoglycemia, or the very preterm ones have a German matrix hemorrhage. They could all get seizures because the brain is getting affected, but that is not epilepsy. Okay, patients, adults who have hypoglycemia or have trauma, have brain injury, they will have seizures at the time of presentation. Kids with pediatric stroke very often presents with a focal seizure, but these are all provoked seizures and do not constitute epilepsy, so do not require long-term anti-seizure medications. I think this is very important. Typically, yes, you will give them anti-seizure medications acutely to stop the seizure, but then at the time of discharge, you're going to try and come off the anti-seizure medications. Then the second question is, is this a non-epileptic event? And there are so many non-epileptic events that can look or mimic epilepsy. So I'm going to try and show you a couple of videos to exemplify this point. My hyperlink is not working, so I'm going to open each video individually. So this is one of the common scenarios. So just pause the video for a second. If you can't see the video, please let me know. But this is a child. This is a video actually from sent by one of my residents from the hospital. This is a 2-year-old baby, neurologically normal, no problems. But every time he cries, this is what happens. He's gone all stiff. Right now his eyes are closed. Unresponsive. You can see he's lifted. That tells you there is a general electronic component. Now you can see the eyes are deviated to one side. He's still unresponsive. Now his eyes look like they're rolling. Still looks like he's altered completely. And that's it. He's out of it. He's out of it. He started looking around. And he's playing as if nothing's gone wrong. So this is a very typical breath holding spell. And the clue was not in the latter part of the video. The clue was in the first part of the video. And I'm going to play that to you again. And that's the fact that he's crying. And then he experienced what looks like a generalized tonic seizure. Okay. But the context in which this paroxysmal event happened was crying. And then you can actually see him holding his breath and go a little bit sinused. And then have a generalized tonic component to the paroxysmal event. So this is not a primary epileptic seizure. This is a breath holding spell. Very often has the potential to get misdiagnosed as an epileptic seizure, because very often people just see this latter part, which is the more dramatic part of the event, and that is what gets told to you by the eyewitnesses on history. So it's important that you and I ask the question, saying, "Jabi so-called fit aya, takleef hui, tabhi bacha kya kar raha tha? What was he or she doing?" Start with that. Was he awake? Was he asleep? Because from sleep you get non-seizure mimics like physiological sleep myoclonus, and I'll try and show you a video of that as well. So if somebody tells you that no, these events are only happening from sleep, now look at that. This is the little sleep myoclonus, and you can see there is jerking of all limbs, sometimes single, sometimes together, very synchronized. Sometimes there are fast beats, sometimes there are just single jerks. Despite restraint, these are not stopping. And just going to pause the video there. Remember, especially newborns, if they're having jerky movements, a very quick, useful bedside test is restraint. If you restrain and the baby stops jerking, then you know that this was possibly a shuddering or a jitteriness, which is very commonly seen in newborns. But these events, despite restraint, they're going on. But again, you go back and ask the history. Of course, the video tells you that the baby is sleeping, but you go back and ask the history, saying, okay, when did you see this jerk? Is it only in sleep and none in awake? Then you know that it's a sleep-related phenomenon, and then you know that very likely this is a sleep myoclonus. Because if it's a true epileptic seizure, and of course, at one unprovoked event, it's a little bit difficult to come to a conclusion, but ask history, saying, has this happened before? And then somebody might just come up saying, yes, every time the baby sleeps, this happens. And not just babies, older kids, and in fact, adults too. And it only happens in sleep. Then just on history there, you have a you have a diagnosis of this being a high probability of this being a sleep phenomenon, a sleep myoclonus. Then this is another video I wanted to see. This is one of my old patients. He had severe jaundice at birth. He received and exchange transfusion. But you can see he's stiff. He's very, very stiff. And in fact, he's arching his back. Okay? So this is dystonia. What he's doing is he's completely arching his back. He's almost orthostonic. This is dystonia. But the description, especially in the initial days when the cerebral palsy is evolving, and remember these are kids who already have neurological abnormality. They have been in NICU either for hypoxic ischemic injury or a severe connectors, or they've been severely preterm, have had a stormy rocky course. The development is already delayed. And then these paroxysmal events start happening where they're going stiff. Kabhi ek hi haath stiff ho raha hai, kabhi pura badan stiff ho raha hai. Again, ask the context. जब भी पूरा बदन स्टिफ होता है तभी क्या कर रहा होता है, जगहपन में होता है, नींद में होता है. If it's dystonia, it will almost never happen in sleep, will only happen in awake. Not just awake, they will give you context saying बहुत गुस्से में है, दर्द हो रहा है, रो रहा है, बहुत खुश है तो ज्यादा दिखाई देता है, पर होश में रहता है. So you already have a generalized tone abnormality which sounds like it's provoked by emotion, only happens in awake, despite it being generalized, there is no impairment of awareness or consciousness. Then you know that this is very likely dystonia rather than it being primarily epileptic. So these seizure mimics are very important for us to recognize, and very, very often it's history that will and history with detailed leading questions, almost saying what was a child doing when this happened, is there a provoking factor, what is important. Now just look at this last video of a seizure mimic. This was a girl who was diagnosed with epilepsy, but overall had well controlled epilepsy, and now see what's happening. So this is a home video. She's having jerking of all limbs. It's very rhythmic. Okay. But she looks very awake. She looks very alert. Okay. And in fact, giving her the nasal midazolam spray because her mom's being trained to do it because they've been living with epilepsy. And see, the jerking continues and she looks all awake. This is actually used to get called a non-epileptic event or a pseudo seizure. This is a very difficult situation in which the actual epilepsy and pseudo seizures or dissociative events coexist, and makes it that much more difficult to manage and diagnose. So that was a quick look at lot of seizure mimics. Another important one that we see is syncope. Again, if you ask the child the context in which this happens, they will tell you, "Ki, I was standing, I was feeling hot and bothered. I felt that my vision was going blurred. I felt that I'm going to fall down." And then they might have a event in which they might become unconscious. They might have tonic phases. They might have clonic. But because the context is that they had an aura which tells autonomic disturbance, very, very likely that event is syncope rather than being an epileptic seizure. So the look can mimic that of an epileptic seizure, but the underlying pathophysiology is not that of a gray matter abnormality or a neuronal dysfunction starting off as a primary event. So very often the history and the context will give you the clue that this is actually very likely a seizure mimic and not a primary epileptic seizure. Okay, so moving on to the next classification. Sorry about that. So you've done your history. You think that this first unprovoked event was actually epileptic, and the history has told you that. Then the next question that comes to your mind, and of course the patient's mind, is if this single seizure was epileptic, then is this epilepsy? Is my child suffering from epilepsy? So to answer that, let's look at the definition of epilepsy. So a person is considered to have epilepsy if and this is a definition most of us learned when we were younger, if they've had 2 or more unprovoked seizures occurring more than 24 hours apart. So that is what is epilepsy. So of course, if it's the first unprovoked event and you think that this is an epileptic seizure, then you're going to try and ask for history, which might help you to get this data. Saying, is this truly the first event, or were there similar events in the past which was either similar or which was different but were epileptic seizures? And if they've occurred at 2 different time points, then that history itself tells you that this child or this adult have a tendency to have recurring epileptic seizures, and that is what is epilepsy. And this was, of course, a simple definition that all of us learned, very, very straightforward to use in practice. However, in 2014, the ILA modified the definition of epilepsy and added 2 further criteria by which you and I could diagnose epilepsy in clinic. So the second one is, I think, what's important, very important, of course, given our talk today, that just would you diagnose epilepsy with a single unprovoked seizure, but also from a very intuitive perspective as a clinician as to how do you understand epilepsy, how do you look at epilepsy. So the second point looks a bit convoluted, but just bear with me, I'm going to walk you through it. So the second point, I'm going to read it for the benefit of everyone. The second point says 1 unprovoked seizure, but something and a probability of further seizures. And this probability is similar to the general population risk of recurrence of seizures after 2 unprovoked seizures occurring over the next 10 years. Very complex, very convoluted. Let me tell you what this means. What this means is, if you have a patient, adult or pediatric, with 1 unprovoked seizure, you've done the history, you've taken the eyewitness account, you're pretty sure that this first paroxysmal event was an unprovoked epileptic seizure. Then you and I are going to try and look for data which tells us that that child is at risk of having another unprovoked seizure, and which is much higher general population risk, but is similar to patients who have epilepsy. Okay, so what in the history tells you? So this is a clinical judgment. Okay, so what is it that will tell you in the history that that child is at risk of having further seizures? And you have to decide this at a time point of the patient having experienced only 1 single unprovoked epileptic seizure. Okay, so what are the points in history? And examination as so clinical points. One is, of course, the history, saying, is this child, did they have any brain insult, any brain injury which is known to cause epilepsy? So does the child have cerebral palsy? Did they have a head injury? Do they have a cortical malformation? And cortical malformation, for example, they could have a neurocutaneous syndrome, where you're seeing lots of hypopigmented spots, café spots. You know that this is possibly tuberous sclerosis. Then you know that there's a high risk of epilepsy. So something in the clinical history, etiology-wise, or something in the clinical history from a brain function perspective. And we as pediatricians are very lucky. The milestones tell us a lot about how the brain is functioning. And so if there's a developmental delay, you know that there is brain dysfunction. And that again puts this child at risk of experiencing epileptic seizures, with epilepsy as being the other symptom of the underlying etiology. The third thing is examination. Is there microcephaly? Is there abnormal tone? So the neurological examination, is it abnormal? So one or all of these factors, and depending what it is, helps you to arrive at a probability of whether that child is going to have further unprovoked seizures. Is it at a high risk of having further unprovoked seizures? And of course, the diagnosis of an epilepsy syndrome, which is very, very often given to you by an EEG. So I think this is very important. So if you have, I'm just going to reiterate this point again. If you have somebody with a single unprovoked seizures, please look for clinical clues which will tell you that this child could have further unprovoked seizures, because then you're starting to think that this is a child who possibly has epilepsy, versus just a pure unprovoked seizure in a completely neurologically normal child with no risk factors in history. Your approach will be very, very different. In both cases, I think you need to, because the third point is diagnosis of an epilepsy syndrome, which very often the EEG gives you. So in both the cases, do offer an EEG. Please do an EEG properly, and I'll very, very briefly talk about the valid utility of an EEG. But do an EEG properly, I mean, do it in the right circumstances, get a awake and a sleep record, and please use pediatric or adult parameters depending who is it that you are recording. So with that understanding of epilepsy, the ILAE has gone forward and now classified seizures. We were always classifying seizures. Focal seizures were called petit mal or partial. Now we are back again to focal. And what focal means is that the awareness is preserved, at least at the seizure onset. And again, the history tells you that, the child I'll probably try and show you a couple of videos of that. But the history will tell you कि वो उसने बच्चे ने आके बोला कि मुझे कुछ हो रहा है और फिर कुछ हुआ, या मम्मी किया या बैठ गया, so you know that they experience the onset. So very likely this is a focal seizure. Of course, it could secondary generalize. Whereas generalized seizures, awareness is impaired right from the word go, and that's because the epileptic circuit involves both sides and of course large areas of the cortex, and that is why it's a generalized seizure. This used to be called grand mal previously. The classification doesn't stick to focal and generalized or unknown. It's now, there's a very elaborate classification, but I don't think that's the scope of our talk today. Focal can be motor or non-motor. Generalized can again be motor, non-motor. And I'll try and show you a couple of examples. And remember, the classification has a type of seizures called unknown. So if you and I are not able to elicit on history whether this was a focal onset or generalized, please park it in that unknown category, and that's perfectly fine. You may get data down the line which might help you to reclassify it into focal or generalized. So what are the seizure? So when you have focal and generalized, you can have focal seizures with awareness preserved and focal with impaired awareness. Then you have infantile spasms, which can be focal or generalized, and I'm going to show you a quick video because I think it's very important for all of us to know infantile spasms. I'm very sorry, it's not opening from the hyperlink. The video. Lying in his mom's lap, and then this has a jerk. The same jerk keeps happening in a cluster. The typical story will be chamak raha hai, chowk raha hai, gachak raha hai, and they will happen out of the blue when he's playing. I don't think this video is playing. Okay, there he is. There is a flexion of both his upper limbs and lower limbs. It's very brief. But this will happen in a cluster, typically on waking up from sleep, and typically in patients who have been ex-NICU graduates. So this is a typical infantile spasm, flexor extensor, salam spasm, as it got called in the past. This is one seizure type, which is actually emergency. These are kids who have to be seen very early. They need a very urgent EEG, ideally on the same day, because this is very often as part of West syndrome. And we urgently need to start steroids. Because it's an epileptic encephalopathy and the chances of treatment, one of the factors which affects prognosis is how soon was the treatment started after seizure onset. So this is one clinical situation and one of the rare clinical situations where we need an urgent EEG done. Now let's see at another another generalized seizure. This is a kid doing hyperventilation. He's a normal child. He's come saying he has blank spells. He just stopped abruptly. He didn't know what's happening. I'm asking him to remember a color. He doesn't remember it.
Okay.
I asked him what happened. He doesn't know. And he doesn't remember where he stopped counting. Okay. So literally he just went blank. He went absent for a few seconds. And the counting is just done to demonstrate on video as to how he goes blank for literally 8 to 10 seconds, snaps in and out of it as if light on kiya, light ban kiya, is that abrupt onset and offset with no recollection. This is a very common type of epilepsy called childhood absence epilepsy, which you can provoke in clinic by hyperventilation, and you have a diagnosis. Then I'm going to show you another seizure type. This is a kid who's sitting. He's undergoing a video injury. He's sitting, he's very much aware. Now look, he goes unaware and he suddenly drops down. And they're trying to talk to him. He's unresponsive. He doesn't give the command that the nurse is giving him. He's unable to answer questions. And now
पे दे देंगे बाद में नहीं यहाँ दे देंगे नहीं देना तो
so this was a atonic drop attack, another type of a generalized seizure. So you've seen 2-3 types of generalized seizures, and I'll actually show you GTC before we go on to focal seizure. So this is again a video EEG patient. He's undergoing a video EEG. He's gone tonic. Whole body is gone stiff. Face is cold and stiff. There's a frightened tone. Head is cold to his left. Both arms are getting elevated. Now the face is getting pulled, and now you have facial chronic starting. Now the head is a head down to his right. Typical chronic event happening. And the technician is talking to him, trying to get a response, and there is no response from the window. Okay. When we ask him, he's a normal functioning adult. He doesn't know that the seizure is going to happen, nor is he able to. There's complete awareness impaired throughout the seizure, and he's amnestic for the events. So this is a typical generalized tonic-clonic seizure. I'm going to race through the next video and get to the slides time. But after having seen so many generalized seizures, now look at this one.
Red color.
She looks away.
Red color.
She's looking at the technician. She's making some lip smacking movements. She's playing with her clothes, with the bed sheet. But she's not answering. Okay. So clearly this is a focal seizure, but there is impaired awareness. So this is a focal seizure with impaired awareness. So you can see how it can mimic how this can come to you saying absence again. But if you keep asking questions saying how long, this is so much longer than the boy with the hyperventilation. In this, she looks like she's aware but isn't able to answer any questions. So if you ask all these questions on history, saying in what context did it happen, did they look aware, did they come to you beforehand, ask the patient. Even 3- and 4-year-olds might tell you कि मुझे कुछ हुआ था, मुझे समझ में आया. They might draw it for you sometimes. Occipital seizures have beautiful drawings from patients where they've drawn it, saying that was the aura. So try and elicit the history, and that might help you to reach a conclusion saying, was this a focal or a generalized? And that's an integral part of being able to manage these patients in the long run. So moving on, how do we diagnose epileptic seizures? I think I've said it umpteen times. It's history. Try and talk to the eyewitness if it happened to the tuition teacher or in school. Call the teacher, try and get the context of it which happened, reconfirm it was unprovoked. Check with the child as well, not just the eyewitnesses saying, was there any aura? And the aura might take you to an epileptic seizure or to a syncope or to a migraine. If more than one event has happened, please ask, were they all similar? Were they all different? Were they brief? Were they prolonged? So get history, which will literally help you to visualize the paroxysmal event as it happened. Moving on, there are some things which don't necessarily say that these events were epileptic, and this is incontinence, tongue bites, so-called jerks, postictally if they were very washed out. These points are common to epileptic as well as non-epileptic events. Okay. Also remember, kids with abnormal neurology can have epileptic events as well as non-epileptic events. So yes, underlying neurology is very, very important, especially in the context of a first unprovoked seizure. Makes you look harder and think harder whether that unprovoked seizure was epileptic and does this child have epilepsy. But it could be a red herring. And please address each event at face value. Just because some kids can have two different types of events, and it's important to know to be able to differentiate between them to reach a diagnosis of epilepsy. So the real cheat sheet is actually your history sheet to diagnose whether the paroxysmal event was epileptic or not. And then, of course, whether it's epilepsy or not, the clinical abnormal, you're looking for abnormal neurology, and then you're using an EEG very judiciously, an EEG done the right way, which might help you satisfy that second and third point of the epilepsy definition as to whether this child is at risk of having further seizures. A big, like a warning almost, a normal EEG does not rule out epilepsy, and an abnormal EEG does not always rule in epilepsy. If it's an abnormal EEG, a lot depends on what is the type of the abnormality, which would decide whether that child has epilepsy or not. So please do EEG with not a pinch, but a fist of salt when you do it. And be guided by the clinical. That's probably the most robust factor that will help you towards the right diagnosis. Other investigations, like especially imaging, really does not take you towards or away from epilepsy. We do epilepsy surgeries on patients who have normal MRIs. On the other hand, all of us see patients who have large areas of cystic encephalomalacia on MRI. You know they have cerebral palsy, but never experience an epileptic seizure in their entire lifetime. So after a first unprovoked seizure, imaging does not confirm or unconfirm the diagnosis of epilepsy. The paroxysmal event has to be judged on its own merit, which is clinical. And honestly, it may not do MRI in certain definite genetic epilepsies like the childhood absence that you saw. However, in all focal epilepsies, there's a focality. They should have a good quality imaging done. Etiology of epilepsy, it's a heterogeneous group. It's a symptom complex. Broadly speaking, however, it's genetic versus structure. Okay. And epilepsy genetics is very, very exciting. We're in the age of precision medicine, but that's for another day. But do remember, a lot of epilepsies, especially the MRI negative ones in kids who are otherwise normal, are genetic. And of course, they'll be structural, in which there could be acquired brain injury like gliosis, secondary to HIE, stroke, and so on and so forth. Or they could be structural malformations like cortical dysplasias and hemimegacephalus. If you think that the child now has epilepsy, then please try and work your way towards an etiology, because that's important. That is what determines whether this child will have any comorbidities with respect to development. That is what decides how you manage the child, which anti-seizure medications you use, and that is what will decide how you counsel these families regarding the outcome. It's epilepsy, yes, but what's causing the epilepsy is really governs how we look at the outcomes. So long-term treatment, the last part of my talk, do we need treatment in everybody who comes with even epilepsy? Not at all. Please avoid trials of treatment. There's one unprovoked seizure, 3 mahina, 6 mahina dawa deke dekhte hain. That does not make you any wiser. If your clinical is not saying this is epileptic and that there's a chance and that this is epilepsy, the medication isn't going to make you any wiser. So absolutely avoid trials of anti-seizure medications. If you start anti-seizure medication, thinking of it, the goal is to reduce the risk of future seizures. Seizure freedom, yes, but in the severe epilepsies or the epileptic encephalopathies, anti-seizure medications do not give you seizure freedom. So be a little bit wary of that. You want to do this while avoiding significant adverse effects. Okay, so those are the goals of treatment. What are the expectations from treatment? Well, it depends on the underlying etiology of the epilepsy. The etiology will decide how well will a certain anti-seizure medication control epilepsy, whether it will control it at all or not, and what will be the long-term neurological outcome in that given child. Quickly coming to which is the correct anti-seizure medication. There are two types of anti-seizure medications, broadly speaking: narrow spectrum, which are only effective, as the word suggests, against certain seizure types, typically against focal seizures. So these, if used inappropriately, might exacerbate certain other seizure types. And then there are broad spectrum anti-seizure medications, which are effective against a wide range of seizure types and epilepsies, unlikely that they will exacerbate. So if you're in doubt as to which type of epilepsy it is, it's in that unknown onset classification, stick to broad spectrum anti-seizure medications. The two goals of anti-seizure, though I do epilepsy surgery and so on, are these two medicines, sodium valproate and carbamazepine. Sodium valproate is a fantastic broad spectrum anti-seizure medication. The only real caveat is certain metabolic diseases, which are rare. And of course, girls who are pubertal and ladies of childbearing age, we're worried about fetal valproate syndrome, but otherwise, really an effective broad spectrum anti-seizure medication. And carbamazepine, a very effective, easy, well-tolerated narrow spectrum anti-seizure medication. How long, the last part, how long do you give anti-seizure medications? There is no answer. There is no one answer which will answer this question. Okay, because one size does not fit all is the mantra here. It depends on what's the etiology of the epilepsy, how long will you treat, and like I said earlier, whether you treat at all or not. You only give 6 months of sodium valproate. Certain genetic early childhood onset epilepsies like Rolandic, you may not give any treatment or give a very short treatment for 2 years. Childhood absence, you will give anti-seizure medications for 2-3 years. But other genetic generalized epilepsies, which start in adolescence and adulthood, like JME, you will give lifelong anti-seizure medications. So it's the epilepsy syndrome or the proposed etiology of the epilepsy which decides how long is the treatment going to be. But broadly speaking, if this is a child who is well controlled, there are no specific factors in the history which take you to one or the other side. Say a lesional epilepsy has CP, has had a few seizures, and you want to think of coming off the anti-seizure medications after 4, 5, 6 years. Then broad considerations are how many anti-seizure medications did you take to control the epilepsy? How easy was it with respect to the epileptic encephalopathy aspect? How bad was the EG? So these might be a few broad questions that might guide you, but one size does not fit all. The duration of the anti-seizure treatment is going to be tailored to the etiology and how the epilepsy, even within etiology groups, how the epilepsy has behaved in that given child. Because in a similar etiology, we know you can have a mild or a severe epilepsy. So I'll end with a take-home message saying, if a child comes to you with a first unprovoked seizure, the first question to ask is, was this epileptic or non-epileptic? And if epileptic, then you're asking yourself a question, is this epilepsy? But it can have many pitfalls, and it's history really which guides you to a working hypothesis. If you can't reach a conclusion, park yourself saying an undefined paroxysmal event. Talk about first aid, talk about patient safety, but don't rush or hasten into a diagnosis of epileptic versus non-epileptic. Give it time, have this discussion with parents saying we don't have enough to know more, and let's see, but take care of patient safety in the meanwhile. Be very aware of the limitations of investigations. And if you think it's epilepsy, please try and use these very same investigations to help you to get to an etiology, because that's crucial for the practically managing the child and setting expectations. Thank you. Any questions, or do you
Yeah.
think we can go on to the next speaker?
Thank you, Pradnya, for very nice talk. If there are any questions, please unmute yourself and ask directly, or you can write in the chat box and we will pass it on to Dr. Pradnya. I think everybody understood everything about epilepsy in children. One second. Our next speaker is Dr. Puja Mehta. She is also pediatric neurologist associated with SRCC Children's Hospital, and she will be telling us about approach to headache in children. Puja, you can give a short intro and then continue.
Okay.
And when you are done, you can introduce the next speaker, Dr. Anaita Hegde. And Dr. Anaita Hegde should introduce Koyeli Sengupta. If I am around, I may do it. Otherwise, you people can continue.
Sure, sir.
Okay.
Okay. Yeah, I'm Dr. Puja Mehta. I'm one of the neurologists at SRCC Children's Hospital, and today I'll be talking about headache, which I am very interested in. My screen is visible, right?
Yeah, it is visible. You can do slideshow.
Okay. Okay. Yeah, got it. Okay, so I am going to be talking about pediatric headache. It's not as uncommon as we think. And I think as primary care physicians or neurologists or any specialists, we need to know a little basics about headache. So what do parents think when a child complains that, Mom, I have a headache? Most of the time, the first reaction is no, just making it up. Headaches don't happen in children. It's an adult thing. If it's a second or a third headache, parents will be like, no, you're just making it up. You don't want to go to class. Don't want to study. My child is just making it up. Or my child, let's go to the eye doctor. So most children, before they reach you or me, will have had a visit to the eye doctor to say, think that a child needs glasses. Some parents think very overdiagnosed headache condition is a sinus headache. Oh, it's just sinuses. My child has a sinus headache, nothing to worry about. And when the headache is recurrent or it's a severe headache, which is making the child cry, every parent's worst nightmare or things they never want to come true is, does my child have a brain tumor? And that's the time they come rushing very worried to you or to the neurologist. So headache is much more commoner than we think. It's quite underestimated, undertreated throughout the world. And I think especially in our part of the world where, we are more stoic when it comes to pain, dealing with pain, it's just kind of pushed under the rug. Headache prevalence, headaches of all types, the prevalence ranges from right to about 7 to 8% in 3 and 4-year-olds to as high as about 75 to 80% in the teens and preteens. This is all headaches types. Migraines are about 5 to 10%, going up to 15% in children. That I think is also a pretty high number. In fact, you might have seen a recent increase in the headache prevalence. I have post-COVID, call it the post-pandemic effect, or this is also the time when there was a lot of behavioral and mood issues in children, school anxiety, refusal to go to school that came up. So all of it, we are definitely seeing a change in lifestyle and an increase in the incidence and prevalence of headaches. So all the more imperative that we should know a little more than a little bit about headaches. Why is it important to diagnose the type of headache and treat and manage headaches? Because anybody who's had a headache, you know how horrible it feels. It negatively impacts your quality of life. School is missed. They miss out on their classes. They miss out on physical activity. Can't go to a birthday party. Now we're at home with a headache. Headaches typically come or are triggered by when there is a class test, when there is an exam coming up. So there's a lot of school absenteeism. You've missed your grades. You've missed scoring good marks in your exam. Now there is more stress about going to school. It also headaches and specifically migraines come with a lot of other comorbidities which also need identification. So allergies, sleep disorders like sleep apnea, a lot of emotional behavioral problems, specifically depression and anxiety, and academic issues are linked with migraine. So important to identify the headache and give it the type. So what we need to know in today's talk or takeaway would be to identify if this headache is benign. Is that tumor that the parents are really scared of? Is it a primary headache versus a definite intracranial pathology that is a secondary headache? We need to differentiate that when the child comes in to see us. Identify that, okay, if it is a benign headache, it is a primary headache, what is the type of the headache? Identify the triggers causing the headache and identify which patient you need to work up and which patient just needs reassurance. So there is no specific test or lab test or imaging that will tell you that, yes, this headache is a migraine headache or a tension type headache. Headache is generally a clinical diagnosis. The tests are only to aid us in ruling out secondary causes. So the devil is really in the details. The first evaluation is the one where I take the maximum time. You take at least 45 minutes to an hour sometimes to get all your details. A detailed history and a detailed examination is absolutely necessary to identify the headache. So starting off with how long the child has had headaches. Is it a few months? Is it a week? How frequent are the headaches? How long does the headache last? Is it a few minutes to an hour to a whole day? The child can most of the time reliably tell you where is the location of the pain and how severe is the pain. I think it's easier for the older child if they can assign a number. I generally ask them to rate the headache, say on a scale of 1 to 10. So on follow-up also, you get an idea of are the headaches getting worse, are the headaches getting better when you have an objective like a number. Trigger factors. We'll go over that a little bit in detail, but most common trigger factors that we ask for is sleep deprivation. Is the child missing meals? Is the child drinking enough water? Any psychosocial issues at home? For example, anybody in the family. So children process stress in different ways. One of it may come off if they are stressed. One presentation may be a headache. So if there's somebody ill in the house, somebody recently passed away, a new member in the house, any issues at school. I also take time to talk to the child just by themselves. Throw open-ended questions. Is there something bothering you? Is there something you would like to tell me? And believe me, more often than not, it is very, very easy to identify that there are psychosocial issues going around. Aura symptoms. I'll come to that a little bit in detail, and any associated symptoms with the headache. Nausea, vomiting is key. Photophobia, phonophobia. Many times you have to give the example that do you need to switch off the lights when you have a headache? Do you just want everybody to stop talking? Do you tell mommy to just switch off the television? If the headache is in school, do you feel that everybody just needs to quieten down when you have a headache? So that tells you whether there is photophobia or phonophobia along with the headache. Dizziness, flashes of light. The older children will be able to tell you, but the younger ones, the 6-7 year olds and younger may not be able to reliably tell you that there is that there are associated symptoms or even an aura. What you will notice is for the younger children with the headache, there is a change in the behavior. There is irritability. They just want to lie down and not be bothered. Any specific relieving factors for migraines? Typical history is I feel better after I've had a nap. So headache typically resolves with rest in a quiet room, in a dark room. Any symptoms in between the headache? How well is the child doing in between the headaches? So very, very important to take a detailed history of the headaches, how the child's lifestyle has been impacted because of the headaches. Are the headaches increasing in frequency, decreasing? Were we having intermittent headaches to now transform to daily headaches or not? Physical examination, extremely important. Blood pressure, if not checked, should always be checked. Weight and height, of course, to make sure the child is thriving well. There is no failure to thrive going on. General exam and ENT, make sure the teeth are all right. Many times a headache can be referred from the teeth. So I saw a kid with very severe headaches who, of course, went to the eye doctor, got a pair of glasses, still headaches getting worse, and he had 6 scary teeth. And his headaches were gone after his teeth were taken care of. So always look at the mouth. Sinuses, look for sinus tenderness if there is a cough or if there is a cold fever going on. Neuro exam, if you can look at the fundus very quickly, need a detailed exam or there is a suspicion that the disc is a little blurred, definitely send them to the ophthalmologist. And then a full neuro exam to see whether we have any focal neurological deficits, look at the gait, look at the reflexes, see if there's any weakness on one side. So a detailed history and examination will in majority of the cases tell you that yes, this headache is a primary headache or this headache is something serious. Certain associations with benign headaches, you may get a history of colic, travel sickness, there's a history of cyclical vomiting or paroxysmal vertigo where you have these brief self-limiting episodes of just vertigo, that is dizziness with vomiting, and child just needs to lie down and then gets better in a few minutes, or abdominal migraine. This kind of just their associations, and it may just add on to the fact that, okay, most likely we are dealing with is a benign headache. So now on the history and exam, once we figured out, yes, this is a primary headache and we can rest easy. There are 4 commonly known primary headache types in children. There are several other ones in adult, like your trigeminal neuralgias and so on and so forth, and the sun CTs, but I will not be going into that because again, less common in children. The secondary causes of headache are your brain tumors, an infection like a meningitis, vascular events, sinus thrombosis, bleeds, strokes, these can give you headaches. Idiopathic intracranial hypertension, which was also known as pseudotumor cerebri. Typical presentation is an overweight female prepubertal coming with headaches, tinnitus, and sometimes with vision issues. Referred pain, as I said, it could be from the eye, it could be from the teeth or the sinuses. History of trauma and headache, so something like either a concussion or somebody with an underlying intracranial injury. Medication-related headaches are also quite common. In fact, my medication overuse headaches is a big problem, especially in the teenage population and the adult population. Post-LP headaches, of course, you will have a history and you would know that, okay, this is a post-dural puncture headache. So coming to the ones that we will be commonly seeing are the primary headaches, tension type, migraine headaches, cluster headaches, and chronic daily headaches. I'll go over each one very briefly. So coming to the migraines, which are actually the second common one. The most common types are your tension type headaches. So a little bit about migraines. Why do they even happen in the first place? So it is a very complex interaction between being genetically predisposed and your environment. So most of the time in migraines, you will have a history of a mom, masi, or a sibling having headaches. And there are specific genes that will cause migraine headaches or certain headache syndromes. What I tell the children to explain why are you having headaches is I just say you have a sensitive brain. That means that you're genetically predisposed to having headaches. And then there are certain triggers or certain interactions with the environment which are causing the headaches. So there are certain food triggers. It could be Chinese food, it could be chocolate, coffee. These are the most common ones. Citrus fruits that can sometimes trigger headaches. Change in your daily life pattern that can trigger your headaches. And what exactly goes on in a migraine is there is activation. I won't go too much in detail, but there is activation of your trigeminal vascular system. And there are a lot of vascular changes happening in place. First, there is a vasoconstriction, and the headache that happens is because of the vasodilation happens. There is a release of lots and lots of inflammatory cytokines, a lot of changes, a lot of oxidative stress that is taking place. And this gradually spreads throughout the brain, starting from it's called cortical spreading depression, starting posteriorly and slowly ascends anteriorly. Involving different structures, especially your pain-related structures, and that's what causes the pain of migraine. So migraine migraine headaches can happen with or without an aura. So what exactly is an aura? An aura is certain neurological symptoms. It could be vision, it could be sensory, speech, even brainstem related symptoms or vision, which are fully reversible. That is very important. You should not be left with any kind of deficit after the aura is fully reversible. It generally starts before the headache has come and it's gone in maximum 5 minutes to 60 minutes. So there are certain symptoms that may come and go, and then you have the headache that starts. And there are ICHD criteria for migraine. They're easily available online. So you have to have at least 5 attacks fulfilling these criteria. They're lasting for a few hours. They're unilateral throbbing. It may cause limitation of physical activity and should be associated either with nausea, vomiting, or with photophobia, phonophobia. Now, the caveat is in our pediatric patients, you will most of the time not satisfy these criteria. They are not able to say that it's a pulsating quality. Sometimes the pain may be bitemporal in all their attacks. Sometimes the pain is not severe enough to limit their physical activity. Most children just continue through the day or they continue to play. So just something to keep in mind. We may not always satisfy all the criteria. Key features for migraine are the light sound sensitivity, change in behavior. Headaches may be bilateral, as I said, and it could just be frontotemporal most of the time. Next one are the tension type headaches. These are a little more commoner than migraine, also known as stress headaches. And this is what a lot of adults will tell you. I get this headache when I'm very stressed. I get this headache, when I'm very worked up about I have a deadline to meet at work. I get a stress headache. This headache, also we have specific diagnostic criteria. You have to have at least 10 episodes and the headache may last from, let's say, half an hour to sometimes days. And here the pain of the headache is slightly milder as compared to a migraine. Again, it's not aggravated by any particular activity. It may be bilateral and you may continue through the day. It's most of the time, it may just feel like a discomfort. It feels like a typical band around the head, or sometimes the pain is in the cervicogenic area. That's like the nape of the neck. Sinus headaches. This is a very, very common self-diagnosis. They will come and say, oh, my child is having a sinus headache, but this should not be diagnosed. This is not a light diagnosis. Sinus headache, when you call it a sinus headache, is you have to have a pain that is associated with like nasal purulence, obstruction. You have to have a headache. There's the pain, the whole face hurts. And the distribution of the pain in the diagram, this is very typical of a sinus headache. It's just not always in the head. Everything hurts. There will be sinus tenderness on palpation. There is generally reduced a sense of smell. There is fever going on. There is a color. There's a yellow-green discharge from the nose, and the headache generally resolves with antibiotic treatment, and both your sinus pain and headache resolve. So just a light cold and, oh, it's a sinus headache. No, that is incorrect. So again, the distribution of pain tells you about what kind of headache it could be. Migraine is generally unilateral. Tension is like a band. Somebody's tied a very tight band around your head. Cluster headaches, I'll come to that in a minute. And the sinus, as I said, nicely shown in the diagram, it's all around your distribution of your sinuses. Cluster headaches, a little less common in children. So this is the pain. It's very severe. It's excruciating pain. Generally feels like very severe pain behind one eye. It may be associated with tearing, redness of the eye, and the headache can generally last thankfully for a few minutes, generally less than an hour. As I said, again, a little less common, and the description will give you a clue that this is not any other headache. This is a cluster headache, the unilateral and of the eye involvement. So now you've diagnosed that, okay, this is a tension type headache or this is a migraine headache, and we are very convinced that, okay, your exam was normal. There are no red flags on your history or exam, and we're dealing with a very benign headache. Next question always is, so do we get an MRI? Do we not get an MRI? First, let me put it out there that unless you're thinking of a bleed or a tumor, you are not going to, there is no value of a CT scan. If at all, we go directly for an MRI. So it's always the question, always the dilemma many a times, that do we image or not image? We are dealing with pediatric patients. A lot of them may need sedation. It is a procedure by itself. It is expensive. Do we subject the family to going through this whole test in the first place? So there was a very nice paper that came out. So they looked at about 300 plus pediatric patients who had no underlying neurological issues, normal neuro exam. They underwent an MRI for a headache. So 4%, that is about 13 out of 315 patients, had a surgical space occupying lesions. They went back on the history and exam, and they found about 7 predictors that could predict that, okay, there could be an underlying, that could help us know that there is an underlying intracranial pathology for these patients. So sleep-related headaches that happened in sleep, no family history of migraine, headache with vomiting, absence of visual symptoms. So no flashes of light, no Christmas tree lights, no blurring. So no vision symptoms, headache of less than 6 months, so an acute onset headache, abnormal neuro exam, and headaches with confusion, a change in mental status. These could predict. The more predictors, the more accurate prediction that there is something going on. So if you have any of this on your history or exam, then maybe you can push towards, yes, I'd definitely like to go ahead and MRI. For the other cases, you can say, let's wait and watch. So red flags would be if the headache is on one side, if the headache is progressively getting worse, the headaches are getting more severe, more frequent, headache during sleep, headache that wakes up the child in the middle of the night, or immediately on waking up, there's a headache and the child is vomiting. A headache with hypertension, or when the child is not growing, this points towards, okay, do we have any endocrine, so a hypothalamic pituitary problem going on along with a headache? Yes, you want to image this child. Change in vision, a new onset squint, or just change in the behavior overall, just child is just not their usual self, then you want to image these children. A normal neuro exam, normal history, no red flags, you can safely wait and watch. Just a repetition again, these are the ones we are going to test. The extra points would be if you have a headache with Valsalva. Headache with Valsalva would be a headache with coughing, on bending over, headaches in the toilet. Some migraine patients also get headaches on coughing or bending over, but if it's persisted, this history is very, very typical, then definitely go ahead and image. If there's a history of aneurysm, brain tumors in the family, yes, you should err on the side of caution and image them. So coming to the now management of the headaches. So there are several triggers that have been found. This was a study that was done where they were testing a headache trigger app, and what they found was, if you see that these are, now we're talking about the primary headaches, that stress, sleep deprivation, and fatigue, these 3 were the highest reported triggers for headaches. And as you can see, this is all lifestyle. These are things that are easily managed without medication. Noises like strong, loud noises, certain odors, so strong perfumes, going out in the sun, certain foods, weather changes were the other triggers. So what do we do when we have a migraine or we have a tension type headache? Important is the management, or what is known as headache hygiene. Lifestyle modification is key. In fact, you'll be surprised as to how many children can avoid imaging, can avoid medication with these certain lifestyle changes. Spend at least 15-20 minutes going over all these measures. Very simple, but each one is extremely important. One is hydration. Make sure, so most of the time if you ask, the children are not drinking their water, the bottle is coming back full from school, just make sure they're hydrating very, very, very well. I would say at least 10 to 12 glasses. You should be drinking at least 1 to 2 liters at least of water. 1 is minimum, 2 at least is ideal, liters of water a day. And this can be any liquids, but no sodas. No, avoid coffee and tea. Exercise. Now, physical exercise, we know how much effect and the benefits it has, not just for the body, but for the mind. All your good chemicals, your good transmitters are released when you exercise. And now there's enough study to say that headache days per month are reducing with good physical exercise. Children just need to be out in the open and not at home with their smartphones. Sleep, very, very vital. The sleep has to be consistent. It can't be that, okay, I've slept 6 hours at night and then I'm going to sleep for 2 hours in the afternoon. No, the sleep has to be constant, through a constant fixed duration at night. And it can't be that I've slept at 10 o'clock on a school night. Now there's a holiday. I'm going to be staying up till 12:31 and I'll make up for sleep. I'll wake up late in the morning. No, it does not work. There has to be less than 2 hours of variability in bedtime. Just make sure the bedtimes for children are consistent. Most children require 9 to 10 hours of sleep. The younger ones will require even longer. It is because of changes in lifestyle, and their schedules have also become as hectic as ours, that children are really cutting down on sleep. Now, most children I see are not sleeping for more than 6 hours, 7 hours at night, and definitely they require more amount of sleep, and especially the ones who are at risk for headaches. No missing meals, definitely not missing breakfast, snacks, making sure they're eating well throughout the day. Any drops in sugar is going to trigger a headache. More often than not, in fact, actually all children that I see with a migraine or tension type headache, I have them see a psychologist, at least one evaluation. You will be surprised as to the things that come up, the stressors that children face nowadays with our urban lifestyle. And a lot of them are directly responsible for the headache, and just managing this, giving the child skills to manage these stressors can do wonders in relieving their headaches and associated behavioral problems and mood problems that come with it. Coming to the medication bit. Yes, if the headaches you've taken, we're in the process of taking care of our lifestyle changes, practicing headache hygiene. In the meanwhile, if the headaches are very severe, causing school absenteeism, causing a lot of discomfort to the child, we can do abortive therapy, that is taking the medication at the start of the headache. It is important to let the parents know that don't wait for half an hour. Now, 1 hour, child is uncomfortable pain, and now give the medicine. When you know the headache is coming on, give the medicine right at the start of the headache. So, you know, the medicine will start working, the child will feel relieved soon. So the common ones that we generally prescribe, the simplest one is acetaminophen. It can be given every 4 to 6 hours as needed. Ibuprofen comes close. I personally prefer naproxen. One is you have less rebound headaches. Secondly, the onset of action, it starts working in less than an hour, whereas your ibuprofen may take at least 1 to 2 hours for it to start working, and the half-life is way longer. It's about 12 to 15 hours, stays in the system for a longer time. You don't need very frequent dosing, and a little easier on the gut. Ibuprofen is something you should have caution with, that it will cause a lot of gastritis, risk of ulceration, and of course long-term renal effects. So these are the commonly used abortive medications. Now, if the headaches are still not going away, the headaches are very severe, now we have triptans available. There's 2 that are commonly used, that is rizatriptan and almotriptan. Again, reserve these for the older children. And only if your NSAIDs or acetaminophen is not taking away the pain. Use with caution. You should not be using them for more than 2 to 3 times a week. Almotriptan is specifically for the teens with headaches. Rizatriptan now recently is being used for 6 to 12-year-olds. Reserve these only for the more severe headaches. The ones that are now the ones that have like a lot of are having a lot of frequent headaches. Headaches typically more than 3-4 times a month, more than 1 to 2 a week. These are the ones, and the abortive therapy is not just taking care of the headaches. Then there is the role of prophylactic medication. There are several options available now for prophylactic medication. This is medicine for the headache to not just happen in the first place, so it is taken daily. Important thing to tell the parent is, when you're starting on the medication, is that these medicines take time to work, anywhere from 2 months to 3 months minimum for it to really start showing effect. You may see effects, you may see the benefits in the first month, but to really gauge whether this medicine is working, not working, at least 2 to 3 months of treatment is required. Personally, I like cyproheptadine. It's good for the younger children. It may cause a little sedation, so always give it nighttime, and weight gain. It does improve the appetite a little bit, which most parents are happy about, but just do caution about the sedation part. Another commonly used one is flunarizine. It's a calcium channel blocker. Again, well tolerated. One of the effects, key side effects is sedation. It may cause a lot of sedation. So always start off with a smaller dose and then gradually go up, and always given as a nighttime dose. Certain other medications, when you have headaches with certain issues, like you have a teenager who is having headache, is having mood changes, is depressive, or having trouble sleeping, then amitriptyline or nortriptyline is a good idea. Topiramate is another great medication. Keeping in mind, it may cause a little brain fog. It may affect the appetite. So again, a good medication for somebody who's on the overweight side. Propranolol, good one for somebody who's having headaches, who has anxiety or social performance anxiety. But again, use with caution because it affects your blood pressure, and you cannot give it in somebody with asthma. Other used medications are valproate, gabapentin, verapamil, also used for prophylactic medication. Now, if a child is, the parents don't want to do medications, a lot of parents may not want to do our allopathic medications. They want to go for something natural. There are few studies, smaller studies, they say that the natural supplements work. It's fair, you could definitely give a trial with good results with riboflavin, magnesium coenzyme Q. Now, in fact, this is available as a combination tablet also. Children with disturbed sleep at night, melatonin definitely works to make sure, especially the ones that have the late onset sleep phase disorders, the children who are not getting sleep, just not falling asleep before 1 o'clock, 2 o'clock. Melatonin is one for them to enhance, to accelerate that onset of sleep. Less commonly used in children would be a Botox injection, nerve blocks. Again, not gotten proper approval for pediatrics age group yet used very sparingly, but can be used in the adolescent age group. They work very well for the refractory headaches. That are it would be your less occipital or greater occipital nerve blocks. And yeah, so the older population is an option for the ones who are not responding to medication or are having intolerable side effects because of the medication. If the headaches are very severe, the child has to get admitted. The ibuprofen, naproxen is not taking away the pain. These children can be admitted and managed with intravenous medication. Very, very important for any headache, for your migraine, for your tension type headaches, hydrate first. Most of the time, that is that one that will just hydrating them, just pushing saline can relieve the headache. Medications, there are several ones. While training, we used to use a headache cocktail, which was acetaminophen, IV, or ketorolac with metoclopramide and diphenhydramine. Works beautifully for the headaches. There is a lot of nausea, vomiting that adds on to the pain. So for that, either metoclopramide or you can use Finargan for that. The stronger ones, again, less commonly used, more commonly used in the adult population, but our good options are giving valproic acid, methylprednisone, or even magnesium. Dihydroergotamine, you've used it, but again, caution with children who have a history of hypertension or a history of stroke or any history of any cardiovascular disease. My take-home message would be that headache, most of the time, it's a lifestyle disorder. Important to differentiate primary versus secondary headaches. And most of the times, just taking care of lifestyle, the key changes, that is headache hygiene, your sleep, your diet, psychological issues, takes away the headaches in our children. And image rationally, always detail history and exam to make sure we are not missing any red flags, and definitely go ahead and image those children. And that's about it. Thank you. Any questions? Okay.
Puja, I think there's some questions in the chat.
In the chat. Oh, okay.
From which age can we start naproxen?
So there is no restriction with when it comes to age. It's an NSAID, so you can give it at any age. And the next question is flunarizine. Yes, good medication, great medication for headaches. It can be a first line. Just keeping in mind sedation and weight gain are the common side effects. So start off with a small dose. How long can we give prophylactic medications? There is no harm in giving it for long. A lot of children have to be on it for a couple of years. Headaches generally peak in the adolescent age. And then the frequency generally tends to go down. But you definitely want to work on the triggers, on the stressors first, and just not focus on the medications. Melatonin also, again, safe, can be given long, but don't stop it abruptly. Always go down on the dose slowly. Okay, another great question. I was almost going to put it on the PowerPoint. So there is a CGRP antagonist. Very popular now for adult headaches, and they've gotten very good results with the CGRP antagonist. So CGRP antagonists are what is known as calcitonin gene-related peptide antagonist. So CGRP is a very potent vasodilator. So antagonist works on causing vasoconstriction and preventing the progression and of migraine. And it is not approved in pediatric age group yet. So I have no idea whether it's being used on the adult side or not. So I'm not aware of that. But yeah, pediatrics, we're not using it yet. We are waiting to see whether approval comes through. Any relation of screen time and headache? Yeah, definitely, because it does cause an eye strain. It does keep you stimulated, keep you up. It cuts into your sleep time and rest. So anybody with headaches, you have to, or even without headaches, you need to restrict your screen time, and definitely no screen time 2 hours prior to bedtime. Yeah. Yes, yeah, that's what the CGRP antagonists are great. Very good results in the adults. I personally don't have experience using it. Okay. So any more questions? So I think we can move on to our next speaker, who actually needs no introduction, Dr. Anaita Hegde. Sorry. So she is our senior consultant, head of Department of Neurology at SRCC Children's Hospital, neurologist par excellence. And she is going to be talking on clinical pearls in pediatric neurology. Ma'am, welcome.
Thank you. Good evening, everybody. I think you had a lovely session with Puja just now, and my talk will be a little different as compared to covering one topic in toto. I'm going to cover largely case-based conditions that we feel maybe we shouldn't miss, or that you should be aware of, which we may have missed and we have learned through our mistakes over the years. So the first thing we have is, so firstly, as you say, we are all aware that what is the need for a child neurologist? They're not just little adults. The single most important part of a young child is the brain's development. So not only are the disorders different, the presentation different, the outcomes different, the doses and metabolism different, which is the case for all pediatric cases. What we are going to cover today is a bit on neuroplasticity, which is, I think, not a topic or not a case, but I think we need to highlight the importance of brain development in the first few years of life, conditions that we should not miss, lessons that we have learned from our mistakes, and how has our practice changed over the last few years. So the first is, what is neuroplasticity? Now, this is the ability of the brain to change over time throughout its lifespan due to internal or external stimuli. So it's happening to you today while I'm talking, and it's happening to us all the time as we go on. It comes from the word plastico, which means plastic. If you have a bottle of water next to you and you crush it, you see what happens with plastic. You can mold it, you can change it, you can change the form and structure according, because it's a fluid, it's a semi-fluid structure. So if you look at the brain's development from the newborn period to adult life, when you see the newborn's brain dendrites, as you can see here, you see what happens at 1 month, at 9 months, at 2 years, and adults. And you can see that the maximum brain connections ever in your life is at the age of 2 years. After the age of 2 years, what happens is you tend to get apoptosis, which is natural or normal cell death. And eventually, if you look at the adult picture, we can see you have lots of connections, but you have some fibers which are nice and thick and some fibers which are very thin. And the ones which are thick are the ones which have been reinforced repeatedly by doing an activity again and again, and thus by reinforcing neuroplasticity. So what are the types of neuroplasticity we have? One is it's adaptive, which is good for us. So if you have brain injury, you know patients recover very well. The MRI may show severe damage, but you'll see that the final picture isn't that bad. Vision can be reinforced again, people who have visual loss. Hearing can be made better. Physical body damage can be made better. But you also have maladaptive or bad neuroplasticity, which is epilepsy. You have a little scar, you don't get seizures in the beginning, but a few months to years later, the epilepsy starts because it created new circuits, which actually were wrong circuits, and as a result of which neuroplasticity can have its negative effects as well. When does neuroplasticity come into being? The maximum happens in the early stages of brain development, and I will show that to you as we go forward. However, it is not bound to only the pediatric age group. It is throughout life. Even at the age of 80 and 90, we can still be making new circuits, but the chances of laying down a circuit is much less at that age than it would be if it were a child who is younger. Where does this neuroplasticity happen? It happens in adjoining brain areas. So if your temporal is involved, you'll find the area above or below it might get involved. You may get involvement from the opposite side of the brain, may take over the function of the areas which are affected. And the strength, old circuits with peripheral lesions, older circuits might get reactivated over a period of time. So this is a very nice graph for you all to see brain development. And you can see that brain growth is maximum potential happens antenatally. Then we have the orange line is where the potential is maximum. Then it tends to slow down over a period of time, and then we sort of plateau after the age. But where does it slow down? 5. If you drop the graph downwards, we keep growing from 5 onwards, but the maximum arch that you see is in the antenatal to 5 years of age. So this was a lovely experiment which was done on a young boy from the age of 5 years till he reached 20 years. They did functional MRI studies on this child at regular intervals of 1 to 2 years, and they saw how the different areas of the brain lit up depending on what was developing or what aspect of development was undergoing plasticity at that time. So you can see the reds are more motor-related development, and the blues and greens are more cognitive. Can I? Sorry, someone's audio is on. Could I please request it to be switched off? And you can see as you come further down to the blue, it was more cognitive and emotional development. So you see when we see adolescent comes in at 12 to 16 years of age, it's maximum of your cognition and emotional development. And in the youth of your life, when you're a small child, you have more physical development, speech development, visual cortex, other areas which are more involving. So this is a really good graph for us to see how the different senses in our body develop and at what age. Look at the dark blue line, which is hearing, and see where it started. It's almost at its full height when the child is born. Then it stays at the top for 1 to 2 years, and then slowly the potential for developing becomes less. This is why we emphasize the need for hearing aids, the need for cochlear implants. Anything which has to be done with a young brain has to be done early. If you catch them in the period when neuroplasticity is at its maximum, you have the best chance of recircuiting the brain as against doing it when he's 4, 5, 6, 7 years of age, where you can still do it. I'm not saying no, but the effort to make it happen will be exponentially that much higher. Then if you want, look at the others, look at numbers. Number starts developing in the brain 1 to 2 years. It peaks at 2 to 5 years of age. When you think your kid has no idea about numbers and he doesn't know what 1, 2, 3 is, the concept of number is beginning to form in his brain, and he is peaking at that stage for the development of neuroplasticity. Peer social skills, again, peaking at 2 to 3 years of age. Symbol understanding, so sign language, symbol understanding. 1 year is the best time where a child can understand all the symbols and signs that happen. Language development starts really early and it stays high for a very long period of time, and then it plateaus at about 6 or 7 years of age. Vision also starts antenatally. Child comes out, the first thing he does is he fixes and looks at his mother and looks at the face and follows and tracks with that. So vision is very well developed in the first few years, and then the potential comes down. That's why myelination of the brain for the visual cortex is maximum for the first 2 to 3 years, after which doing vision therapy and vision rehabilitation may not give you the results that you were hoping to get as against if you had worked in the first few years. So I think this is a lovely slide for us to understand the value and the importance of please keep your eyes open, intervene as early as possible, because that is the stage where you can make the maximum outcome. This is another sort of graphical description to show you what's at birth. Motor development is already there before, language has already started in between. So the concept of a mom talking the child antenatally, speaking to her child in the womb, listening to music in the womb, we all think that these are hyper parents who are trying to stimulate their child antenatally, but it's not so. It's actually true. The ability for the brain to pick up signals, integrate it, and connect, make connections within themselves starts antenatally. So what exactly is neuroplasticity? How do I do neuroplasticity? So neuroplasticity to me is like, for you to understand, is like a kacha road, a little better road, and then a highway. So what do you do first? When you have something, you pay attention to that thing. You have to focus your attention and concentration on a certain thing, and you start feeling, there's an emotion that comes with it. So suppose I said today I'm teaching you about neuroplasticity, and some of you get interested in it and you go home and then open a book and start reading about it. That's what you're doing. I have instigated a sort of an emotional response in you on neuroplasticity. You're beginning to create a new circuit on that in your brain. Then you repeatedly, you read 1 book, 2 articles, 5 articles, 10 articles, and slowly you are reinforcing that circuit again and again till you make a highway. And you strengthen this pathway by repeatedly thinking about it, but it needs to be with passion. It needs to be with emotion for a circuit to get laid properly. Then you forget about this thing for years. Okay, and slowly you'll find that that highway became a tiny road all over again. Okay, but it doesn't disappear. So tomorrow, if you want to reignite that pathway, it becomes much easier to reignite that pathway as against something which would die out over a period of time. So what influences plasticity? Sensory and motor input. You can understand that. The more you stimulate the child, the more the brain gets signals, sensory signals, motor signals. Psychoactive drugs, we'll come to that. Gonadal and hormones, which is very important. That's a huge spurt which comes in adolescent. Parent-child relationships, peer relationships, stress, the intestinal flora, diet, and exercise. None of these are artificial things. None of these have to be supplemented from outside. These are things that we live with every day. We just need to know how to maximize it. So let me take stress. Everyone thinks stress is bad for us, but stress really isn't bad for us. Stress is a proactive. When you have stress to a certain amount, which is called optimum stress, you perform at your ultimate best. When the stress becomes too much, and you start burning yourself out, it causes anxiety, and then you end up with a complete meltdown which comes. But if it's no stress at all, you're living with boredom, depression, and attention-related problems. Too much stress has its own fatigue, exhaustion, health, breakdown, and burnout. So a certain degree of stress is good. Okay, so we keep saying don't stress the child. To some degree, a certain amount of stress is good. Over stress and burning yourself is not what we need. So this is about stress, which you see the circuits, which is normal stress. And here, when you have toxic stress, what happens to the circuits? This will be seen in the prefrontal cortex and the hippocampus. There's burnout of the neurons because of too much stress. Meditation is one of the good things that has been found. And you can see that with meditation and calming the system and learning to control your baseline, you can improve the ability to concentrate, focus, and for neuroplasticity. Exercise, as you can see, exercise, there are certain, this is the symbols with a child with where exercise has been done and a child in which no exercise has been done. So you see the simple thing, composite of 20 students' brain taking the same test. After sitting quietly and after 20 minutes of a walk, you can see that the brain is so much more activated after exercise and thereby improving the neuroplasticity. Simple things like love and touch, two simple things. You can see institutionalized children and a child who's never been institutionalized. You can see the difference in the brain mapping signals which are picked up in these children. There is distinctly more signals coming from those who are never institutionalized versus those who are institutionalized. The impact of growth mindset intervention, that is stimulation and teaching the child activities which improves their growth and development. Something as simple as mathematics grades before and after an intervention. And this is the developmental change after an intervention. So stimulating your child in the correct form, obviously with good habits, before and after, you can see the difference between them. This is what happens when we mug. Okay, as doctors, we are all famous for mugging. We did that all our academic years. This is actually how your brain learns. After your first study, you lose that much of Sorry, can I request you please to be on silent? After your first study or your first learning, you can see that almost 80%, you only keep 80% of it. Okay, then after the second revision, this is what, you take 2 days or 3 days to retain the 80%. After your third revision, you keep it for 3 to 4 days. And after your fourth revision, so this is what I mean by repetitive learning. So when we do physiotherapy, occupation therapy, all this, what are we doing? We are reinforcing circuits of the brain by repeating an action, by repeating a thought process, by repeating a belief, whether it's psychology, counseling, any of that. So you are relaying circuits in the brain so that they can get developed and then sustain themselves and stay. So this is a very nice video to see how we learn by example. He's eating and you see how reflexly all of us are learning the same thing by watching something. This is the images of people who have psychotropic drugs. So drugs can also affect brain development. So if you have the misfortune of had any drug abuse related activity, if it has been significant and serious, it is not a transient phenomena which comes and goes. It actually can affect the circuits of the brain. And as a result of which your long-term development can get affected. One very important aspect, particularly in the pediatric age group, is sleep. I think people underrate the value of sleep. So good sleep, this is after you've done a learning of something and you've had adequate sleep. This is your recall capacity. And this is your recall capacity if you have crammed everything and then slept for 2 hours at night before your exam. This is your recall capacity. So when we try to tell our children, and when we were told and we didn't listen, I think, in our youth, that please sleep well the night before your exam, or please sleep well when you have something to do. The entire recall of your day's activities, your memories, your thoughts, your learnings, everything gets ingrained in you during your sleep cycle. A quick one, if this is one slide, I would say take a photo of. This is one slide, because I think y'all are the first step when patients come to you. And very often we don't get to see half the patients, or 1/10 of the patients you might see, because they don't have serious neurological problems. But this is a problem which is a silent problem, which I think if we start addressing from day one, we might reach a stage in our lives where it becomes part of our everyday life, and that is the number of hours we sleep. I think we are all guilty of this, each and every one, me for sure. But if we know that we need to see that children at different ages need between 12 hours when they're small to around 7 to 9 hours, or at least 8 to 10 hours till they pass out of schooling age and college age group, at least, I know it doesn't happen, but at least we can guide them for it. Nutrition is a very, very important thing for brain myelin to develop. We don't need multivitamin supplements. We just need a healthy diet, because myelin needs fats, myelin needs proteins, myelin needs selenium and zinc and trace elements for the myelin fibers to grow well. So this is something called the stunting of children. And you can see worldwide the distribution of children who have stunting, the largest part being in Africa, but India has it to some extent. You grow up as a child who does not get enough food and nutrition. Okay, then as you grow, because of the lack of the nutrition on your myelin, your education capacity is not as best as you would have been able to perform. If you don't get adequate grades and your education is not adequate, your professional life takes a hit. You get jobs which are not commensurate with the potential of your IQ because your myelin fibers did not develop. And then we go into another cycle of another family of children. And we have families like this where you have nutritional stunting leading to mental stunting. Growing up poor doesn't just change the way you see the world, it changes your brain. So unfortunately, the access to wealth, or not just wealth, but adequate finances to be able to nutritionally support yourself, educate the child well, give him all the stimuli that is needed in his childhood, all of those things actually have an economic value to them. And unfortunately, if you do not have the finances for it, the entire repercussion and cascade of things get affected. And weight is a very important thing. So if you see the normal brain signals in the basal ganglia for a child and what obesity and hormonal fluctuations cause to it is another thing as well. Stimulation, very important, from parent, from sibling, from teacher, from friend. You can see all the pictures. There's touch, there's vision, there's auditory stimuli, all senses stimuli makes the child improve with time. So in short, 82% of brain development happens by the age of 3 to 4 years. This is not to scare and say nothing more happens. It does, but those first 3 to 4 years are the most important years for brain development. So here is the myth of the first 3 years and the whole brain child. If anyone is interested, it's nice to look into these books to learn a little more about it. But this was a beautiful study which came out of Harvard, when it says the brain's ability to change in response to experience. You look at the blue line. So it's very high when you're 2, 4, 6, 8, 10 years of age. And then it's an exponential drop. But it never goes to zero. So at 70 years, you can also change your brain on experiences. But the effort it takes to change the brain is exponentially inverse. So you can see that the inverse ratio of effort is to brain development over the age. And this is the sad part of life, is this was also came out of the Harvard study, that governments spend most of their budget. Okay, this is what government, this is the brain development. The blue line is brain development, and then we plateau. And government spends very little on brain development, education, and health in the beginning. Then there's a little bump in the school education, college, and then this is postgraduate. Maximum money spent by governments is in postgraduate or in PhD regions, where by which time the brain has already almost learned most of its circuits, or method of learning is always there. So the government budget to brain development is disproportionately panning out. So the takeaway from neuroplasticity is that it's real. It definitely exists. The child's brain grows maximum in the first few years. Multiple factors can influence brain growth, maturity, and plasticity. The desire to learn, repetitions, assimilation in a positive environment, positive, stimulated, nurturing atmosphere are key to laying down new, strong, permanent pathways. However, it's never too late to learn, and the likes of you and I still have potential to learn, but we need to focus our energy, repeat it again and again, and then sustain ourselves in that activity for us to be able to make new circuits. So with that, I covered the neuroplasticity aspect. And I'm then going to go through a little bit of things that we've learned over the years, experience versus knowledge. So information is not knowledge. The only source of knowledge is experience. You need experience to gain wisdom. Knowledge gained through experience is far superior and many times more useful than bookish knowledge. This was Mahatma Gandhi. There is no doubt that all our knowledge begins with experience. Nothing is waste of time if you use your experience wisely. The only true wisdom is in knowing you know nothing and learn all you can from the mistakes of others. You don't have time to make them all yourself. So these are a few sayings that I think we need to remind ourselves with over time, because knowledge makes us knowledgeable. Experience makes us wise. But I think it's mistakes which keep us humble. And you need all three of these to realize how little we all really know. And whatever years of experience or knowledge you have, we all make mistakes, but it's important that we learn from these mistakes as we go. So I'm going to run through a set of cases now till the end of the session and see what take-homes we have from each of them. First child of a third-degree consanguineous marriage, normal birth and development till 1 year, then regression of milestones after an acute respiratory tract infection, started frequent falls, gait became abnormal, sitting with support, very irritable, no history of language and cognitive regression or seizure. So just acute regression at 1 year of age for a normal child after a non-specific infection. She was conscious, very irritable, no cranial nerves involvement, tone was normal, reflexes were normal, planters were flexor, but because of the regression, of course, we did an MRI, we found these basal ganglia lesions with a lactate peak was there. I didn't know what I was dealing with. It looked to me like a mitochondrial disorder of sorts. So I put her on the mitochondrial cocktail at that time. Whether she was an ADEM or an acute demyelinating encephalomyelitis, so she was mitochondrial, I couldn't tell like that. So I treated both the options. On day 3, suddenly she improved significantly and she started sitting up. The ataxia was still there, but she was good. And on follow-up 6 months, the lesions, which to my surprise had totally gone. But I had sent out her genetics because it didn't feel right as to why she should have it. And she was 3rd degree. And she came out to be a thiamine metabolism dysfunction syndrome with a homozygous deletion. And then when I checked parents, both of them were carriers for the same. We had a 3rd degree consanguineous marriage with autosomal recessive inheritance. We had a child who regressed very acutely with a normal development. So we're thinking of some genetic metabolic etiology, but the fact that I could convert it and rectify it to the child is absolutely normal today is not the norm that we normally see. So what we want to take home is that there are vitamin treatable conditions that we cannot afford to miss in the pediatric age group. Again, remember, a growing brain, quick recovery, less damage, best outcome. Pyridoxine-dependent epilepsy, we are aware of that. Biotin-responsive disorders and biotinidase deficiency and a spectrum of biotin. Biotinidase deficiency with other aspects. And what we got here in this case was called biotin-thiamine-responsive basal ganglia. So when you're not sure in any of these, creatinine deficiency is one metabolic disorder you can treat and make it better. Biotin, pyridoxal phosphate, not just pyridoxine, pyridoxal phosphate, which is available, which is the final common pathway for pyridoxine. Thiamine, creatinine, and the ketogenic diet are certain options we should think of when we're looking that can actually reverse a child's metabolic conditions. So if you have an unexplained, till you get a diagnosis, till you refer to somebody, till you get a genetic test, which takes a month or 2, there's absolutely no harm in giving a trial of pyridoxal phosphate, biotin, and thiamine, or the better half of the mitochondrial cocktail, because these can be life-changing. That child will take biotin for the rest of his life, but he will lead a normal life. If I lose 6 months or 8 months before I treat him, I will recover, but I will not be normal. I will have a gap of a certain degree of developmental involvement. This is a 28-day-old of fraternal twins, IVF conception, complains of multiple episodes of paroxysmal movements, staring look with clonic jerking movements, both upper limbs are up-rolling, fluttering of. I saw a spectrum of different types of seizures within the first month of life. It would subside on its own within a minute, but had multiple times in a day. And on examination, there was hypertonia, jitteriness, scissoring, twisting. So if something is already showing you increased tone at 1 month of age, means this has most likely started antenatally. We treated this child was treated with levetiracetam, phenobarbital with no improvement at all. So this was the little child that we had who was having continuous seizures in the ward over here when he came in. So you'll get little jerks. If you can see the low amplitude jerks of the right arm, then there's something, his eyes are blinking over there. Then the left now is slowly going into more. And he's got an EEG, which is showing a run of epileptic activity over here. So he's got a host of different seizure types. So normal birth and development, intractable seizures within the first few days of life, genetic epilepsies or genetic etiology should hit you immediately. So keeping that in mind, I started a drug which we would never have started in the newborn period, and that was phenytoin. And the seizures stopped within a few days. The genetics came back positive for an epileptic encephalopathy. 6 months later, the child has no seizures, but I lost 1 month of brain development with intractable seizures. So I am globally delayed development. In spite of aggressive rehab, I cannot catch up if I had treated him with the correct drug on the first day of life. If I had been able to control those seizures on day 1 of life and not lost the 1 month, I would have had a near normal development, not fully normal, but a near normal development as against significant global involvement. Okay, so just to tell you, I know this may be more than it is, but you have sodium channels, potassium channels. Genetics is now teaching us to understand the why, the where, and the how of things happening inside our brains. And one of the things we need to take home as a message, forget all of that, that if you have early onset seizures, less than 3 months, you get good response with sodium channel drugs. If you have late onset seizures, greater than 3 months of age onset, you do not. So you use sodium channel drugs. If seizures are intractable, less than 3 months of age, you do not use sodium channel drugs if seizures are intractable after 3 months of age. Your sodium channel drugs are carbamazepine, oxcarbazepine, lacosamide, and phenytoin. These are your main sodium channel drugs. So seizure control and development of some epileptic encephalopathies can be life-changing if we choose the correct drug as early as possible. I know this may be beyond our reach for many of them. The genetic report takes a month to come back, but sometimes just early referral when something is looking ominous and you think you're sitting on something which is not just simple epilepsy, particularly in a normal birth history and a normal MRI brain, we need to look at it a little carefully. An 11-year-old girl, first child of non-consanguines, presented with headache for 15 days, squint for 2 days, lethargy, reduced appetite, low-grade fever, traveled from the hometown, has altered, sleepy, 3 episodes of GTC, had a right facial palsy. Her GCS was arousable, irritable, thrashing. She had a forepalsy, hypertonia, and hyperreflexia. She had an MRI, which was diagnosed as a meningioma at that time. Very atypical for a young girl, for a child to have a meningioma, but she was admitted. Her GCS dropped within a few hours to 8/15. She had raised ICB, ventilated, and her CT scan showed she's got this sclerotic lesion sitting in her bone over here. Then over a period of time, I'm going to cut it short, but we thought she had TB. She fitted the picture of TB. The MRI didn't fit TB in the beginning, but then she got contrast and a little hydrocephalus. But her gene expert came negative once. Her gene expert came negative twice. Her gene expert came negative 5 times. We did a brain biopsy on her because she then developed kidney-related problem, liver-related problem, skin-related problem, multi-system involvement. We got the rheumatologist in, we got everybody in. and everything came negative. We discharged her eventually after some time. We had started the AKT, given that we had 5 gene experts negative and a brain biopsy negative. She was then, by the rheumatologist, decided to take down the AKT as we had no justification for it. She came back 2 months later, and that's when, with another facial palsy, and that's when her CSF gene expert came positive. So the take home is gene expert positive, you are 100% looking at TB. Gene expert negative, if your sixth sense tells you if the clinical picture is of TB, please do not omit AKT. Okay, a gene expert negative does not rule out tuberculosis. You can see 5 gene experts in the CSF and 1 directly from the brain biopsy. We still didn't pick it up until 3 months down the line, because this is the sensitivity and specificity, and we could still be missing it in this small window period. This is a 45-day-old child referred for antenatally diagnosed rhabdomyomas in the heart. So what did we see? We saw EEGs. We quickly did an EEG and we found abnormalities. We diagnosed her rhabdomyoma in the heart, skin lesions on the body, MRI is showing multiple lesions, EEG is showing whatever. We thought she had tuberous sclerosis. So we were confirmed and convinced that is there. But till date, in any entity, we never gave prophylactic anti-epileptic medication. We always treat after the child has seizures. So what I want to take home from this case is the only condition till date, or the only anti-epileptic and not anti-seizure medication that we have to date is vigabatrin. Vigabatrin is a drug that works against the growth of the tubers in the mTOR pathway in the brain. And as a result, if you have a child of tuberous sclerosis, you will ask to do an EEG even in the absence of seizures. If your EEG shows any abnormality, you will start vigabatrin even if you do not have seizures. Because those who are treated prophylactically before the seizures come have a much better cognitive and neurological outcome as against those who we wait for the seizures to come and then treatment starts. So this is a lovely paper which came out, Prevention of Epilepsy in Infants with Tuberous Sclerosis. It's an EpiStop trial, and it reduces the risk and severity of epilepsy and cognitive development. So the take home was early treatment for EEG abnormalities has a protective effect on epilepsy and neurodevelopment. Today, vigabatrin is easily available in the market over here. You get it as sachets, so it's very easy to mix it in water and give it to the child. 10-year-old girl, firstborn of non-consanguineous marriage, normal birth and development, came immediately post-COVID lockdown, inability to bear weight on her legs and could not walk properly, had stopped going out. She did not go to school. She stopped playing with her friends because she couldn't walk. So this is her. She could not walk straight. She would go into a run. The minute you said walk, she would go into a run. One leg would keep hopping up like that as she went. And as a result, her arm would go out to protect her. Her MRI was normal, her evoked potentials were mildly diseased, and her baseline chemistry showed that her vitamin B12 was 92. 92 is really, really low. We gave her IV B12 and on the regular once every day for 7 days, once every week for 3 weeks, and once every month for 6 months. That's the full course of vitamin B12 that should be given. And today, touch wood, everything is back to normal. This is another child who is 20 years old, male child, 3rd degree consanguineous, progressively slowness, confusion, longer time to respond, deterioration in gait, and became wheelchair bound by 16 years of age. His MMSEs, or his mental higher function status, had decreased, and he had lost a sibling, a younger sister, to something very similar to this. And when we saw him, she had the same problems and she had eventually passed of it. And this was his MRI with cortical atrophy. We found that his B12 was low, his homocysteine was high, and he was started on betaine, B12 folic acid. His MRI brain has filled out. It's one of the few conditions where the MRI can grow again after you give the correct treatment. And he was picked up to be an MTHFR. So what am I trying to highlight? This is the whole spectrum of B12 related conditions. B12, we harp about vitamin D, but the one thing that's really important that we need to test, at least in all children with adults and children with neurological problems, is B12. So we routinely do B12 and homocysteine in all patients who have neurological issues. So from low mood to sensory neuropathies, to posterior column, to hyperpigment, to neuropsychiatry, to anemia, to developmental delay, to cord involvement, a whole spectrum comes with B12. So it's very common in our country, given that majority of us are vegetarian. A wide spectrum of clinical features manifests as low mood and energy long-term for deficiency symptoms, prolonged period of recovery, hyperpigmented knuckles, and requires injectable and oral for a rapid recovery. So please make it a policy to ask for B12 and homocysteine in all children who have neurological disorders, the entire gamut of cobalamin pathway things, and they are all treatable. Not all with B12, some need betaine, some need something else, but they're all treatable. And I think I'll do this as my last set. This is a 14-year-old male, second born of a third degree, delayed development, abnormal movements, hypotonia, drooling, dystonia. Basically, MRI was normal. This is a 4-year-old male child, delayed development at 7 months, tightness of all 4 limbs, cognitive normal, attending school, spastic, dystonic, wrist reflexes, MRI normal, and a 6-year-old child, third degree, delayed development, microcephaly, minimum activity, motor delay, rolled only at 1 year of age, sitting only at 2 years of age, cognitively delayed, DTRs, MRI normal. So if you try and see what's the common trend in them. So 2 had consanguinity, all 3 have a normal MRI, and all 3 have wrist reflexes, clonus, spasticity, dystonia, with relatively maybe preserved cognition. So they all been treated as cerebral palsy, but all had MRIs which were normal. And none of them have a history of neonatal insult. But one was being treated as CP at 14, 4, and 6 years. The importance of early catching, early brain development is lost if we don't identify these. So this one had dystonia, movement disorder, normal cognition, normal MRI. We gave him a trial of Syndopa, and today he's walking independently, no dystonia, totally normal, going to school. He's DOPA responsive dystonia. 14 years, he was treated as a CP. This was his gene, which was pathogenic, DOPA responsive dystonia. This one is spastic wrist reflexes, normal cognition, MRI, but we did his cervical spine because normal cognition and severe quadriparesis. We tried to find what it was. We had atlantoaxial subluxation. We had a foramen magnum involvement, and today, touch wood, with a lot of therapy, with the Quadkins, AFOs and everything, at least we've got the kid to some degree of independence. And the last one came with a large open AF, very lethargic, dry tongue, coarse faces, slow relaxation. TSH was 327, 6 years of age. We lost that lovely window period, and this child is hypothyroid, which had got missed all these years. And yes, now he started catching up and doing well, but we can't catch up the years that we've lost. So unexplained cerebral palsy. If you have hypotonia, if they have dysmorphisms, if you have a normal MRI brain, if you have a positive family history of sibling affected, sibling loss, relative affected, if you have no perinatal insult, how do we look for perinatal insult? Did he cry at birth or not? Was he discharged very early? And was he by his mother's side and feeding really well within 1 to 2 days? Unlikely that you have anything significant. And what was his condition? Was he taking breastfeeds? Was he Vati Chamach? Was he on RT feeds when he got discharged? This gives you an idea whether the brain was involved or not involved in that period. And if it tells you that no, there was not much involvement, please keep your antennae up and see whether you need to investigate or refer for other causes of suspected cerebral palsy, or what you call cerebral palsy mimics, because some of them can be treated and can change their life. So today, this is a very nice study where you do genetics in these children, and they found that 10 to 20% of unexplained cerebral palsy actually have a genetic etiology. Few quick take-homes. Flunarizine, these are just one little lines on the drugs and some take-home that you should remember. Flunarizine, drug of choice for pediatric migraine, but remember it takes 10 days to kick in. So if you start it and the child doesn't respond with headache improvement, tell them wait for 10-15 days. Then if it doesn't work, you readjust and you see. Topiramate, anti-epileptic medication, significant side effect, temperature, they don't sweat, word finding, renal calculi. I've seen hundreds of children being referred round and round for body temperature, worked up from top to bottom, no cause found. All it needs is increase your fluids or cut the dose of topiramate. Ketogenic diet, remember there are few conditions where it can change their life, GLUT1 deficiency, mitochondrial complex disorders, where you give ketogenic, you can actually make a difference. Gabapentin, clonidine are the two new drugs on the block for dystonia, very beneficial for both types, for children as well as for adult dystonia. Valproate, the commonest drug we use today, very safe, but very rarely pancreatitis is a side effect, so you need to keep that in mind. And riboflavin is a vitamin supplement in the mitochondrial chain, which can get progressive degeneration. It is now available in tablet form in our thing. So there's just one slide on that, what's new in our practice, and basically it's genetics. You must have seen from all the cases I showed you, what percentage of cases we now need genetics to confirm a diagnosis. These are the different types of gene abnormalities we can work. And just one small take home is, today, there are 3 treatments for spinomuscular atrophy, which are life-changing. Okay, these are the drugs that can be used because we've understood genetics. We know where to look. We know how to address it. We now have treatments, very expensive treatments, but trust me, we have 1 or 2, we have at least 5 or 6 on risdiplam. The government schemes are there, ESIS schemes are there. So if you have any children with spinomuscular atrophy, please identify fast, refer fast, and we can help them with a treatment. So this is what you call precision medicine, where once you identify the gene, it can tell you what not to use or what to use. So we did SCN2A and I used phenytoin. If I had SCN1A, I would have avoided phenytoin and lamotrigine. SCN8A, I would have used high dose of phenytoin. SLC, I can only use ketogenic. So you see, when you have a different gene, you can ideally know what drug to use at what dose, and thus help in catching the problem fast so that brain development doesn't take a hit and doesn't get affected. So the take-home messages here are early onset seizures in the absence of perinatal problems need to be reviewed with genetics in mind. Choosing the correct drug can change the entire life of the child. Early diagnosis and treatment with vigabatrin in tuberous sclerosis can be life-changing. B12 and homocysteine should be part of your routine biochemistry workup of children with neurological problems. All those who present a cerebral palsy should have a detailed history. Do not write known case of cerebral palsy, continue therapy, continue this, continue that. Open your files again and see, is this a justified CP or not? Look for the red flags of CP mimics. Genetics has changed the way we practice and we counsel families. SMA has 3 treatments with a gene therapy, which is actually a cure, and precision medicine is here to stay. Hopefully more conditions with gene therapy soon. Thank you. Happy to take any questions. Thank you. Thank you for the thing. I hope we learned a few things. We ourselves learn from the mistakes we make. So I hope we've had a few take-home messages. And the most important is the first 5 years of life. Thank you. I think with this, if we don't have any questions, Dr. Koyeli, are you there? Hi. So with this, we go on to Dr. Koyeli's talk. Dr. Koyeli is one of the best. What ones? Okay, I'll answer that question. Use levetiracetam in pediatrics? Yes, routinely used. Dr. Koyeli is a developmental pediatrician, which is affiliated with the SRCC and the UMI Child Development Center. She is excellent, brilliant, and she is going to take you through a very important topic on how to approach a child with developmental disorders, keeping in mind that today the rate of autism, the rate of behavioral issues, the rate of other stuff, and parents becoming aware of it, and they must be asking you questions in your everyday clinic. And I'm sure she's going to help you as to how to answer those questions, identify the case, and help the child going forward. Koyeli, to you.
Thank you so much, Anaita, and thank you for a lovely talk. I'm so glad I joined in early. And thanks for doing this on Parsi New Year. Well, good evening, everybody, and thank you for staying on for this talk here. So as Dr. Anaita mentioned, that I am going to be talking about a brief approach to developmental concerns in your clinic. So let me share my screen and we'll get started. Okay, so I'm presuming that I am audible and visible. Can anybody show with a hand if people can see my video?
Yeah, we can.
Okay,
Koyeli,
okay, thank you so much. Thank you, appreciate it. Okay, so it's when we are talking about development, we know that we are going to be talking about development in different areas, and that development happens during specific periods. So already we had some lovely talks today, and I heard Dr. Anaita mention about milestones and how milestones have been delayed for certain kids. So which lets us, of course, we know that development in specific areas happens during specific periods. It happens in a sequence. Children do not hop before they learn to walk. Children don't learn to turn over before they are able to hold their heads and things like that. And of course, very, very importantly, that development varies from one child to the other. And when we are talking about areas of development, we also know that the main areas of development that we want to think about or consider is, of course, how the child understands concepts, how they understand overall things, the world around them, which is cognition. How do they understand emotions in themselves and in others? How social are they? How do they play? With toys, with people, with children of their age? How do they communicate? And communication includes both what they learn to say, learn to express, as well as, very importantly, what do they learn to understand of what is being said to them? We want to consider development in their gross motor and their fine motor skills, and we want to see how are children doing in their activities of daily living. And why is that important? Because it's not easy to, just look at a child and talk about, how does this child understand or problem solve? But then if you talk to a mother or a father and tell them, give me some examples of how smart you think your child is, and the parent will say, you know what, when the child's hungry and this is a 1-year-old or the child wants to eat something, he knows. He will be able to point to his favorite box of cookies or things that is kept over there, or that he knows right away that it's now time for us to go down to play, and he will bring the keys down to us, or he'll bring his shoes over. So talking to parents about how their child is during everyday life is such a lovely window to be able to understand how is this child understanding the world around him or her, and how do they problem solve. Now, I think it's important to understand that developmental concerns are real. And in fact, they're probably way more common than what we are even aware of. So all of us have been trained very well, of course, to be able to diagnose and quickly refer families when we see that a child has cancer, has tuberculosis, juvenile diabetes, congenital heart disease, childhood asthma. We know what to do with them. In fact, they are way less common than when we are looking at concerns like autism or attention difficulties, which happen any day at way more rates than what we are seeing for childhood tuberculosis. So for instance, if we are seeing childhood tuberculosis, the prevalence rate for that is somewhere around 2 out of 1,000 kids. Whereas if you are seeing a condition like attention deficit hyperactivity disorder, anywhere around 1 child out of 50 is very likely to have ADHD, which means that if you are the parent of a child who goes to school, it's very likely that your child has one friend or one classmate who probably has ADHD. If you are seeing 100 children in your OPD in a day, it's very likely that you're seeing at least 1 or 2 kids who have ADHD. So the likelihood of these developmental concerns are pretty high. And as Anaita mentioned, that they are often increasing. Now that brings us to the question that who can get a developmental disability? And, Anaita mentioned about the role of genetics, and that's true. Genetics do play a role in when a child or who's a child who can be born with a developmental disability. But the fact is that anyone can have a developmental disability. Any child can be born with a developmental disability, or he or she may acquire it. So which means who's at risk? Can be any newborn who's at risk. But then, of course, there are specific populations who are even more at risk, and they can be due to biological factors or they can be due to environmental risk factors. And these biological factors are ones that you know of, multiple conferences and talks and things, the prematurity, low birth weight, having a history of being admitted in ICU with concerns, major congenital malformations, all of these put children at increased biological risk for having a co-occurring developmental delay or disability. But what's also true in our country, where there are so many people who live in poverty, it is one of the biggest risk factors for children to have a developmental disability, because poverty comes with higher levels of illiteracy, earlier ages of parenting, conditions like maternal depression, and these are very high risk factors for making a child prone to acquiring or having a developmental concern. Now, that being said, what can we do? Short of opening somebody's head and looking inside to peer, is this brain developing normally or not? Unlike the talks you were hearing early, in the field that I work in, there aren't a lot of very objective tests that will tell you, okay, you know what, this is ADHD. Okay, this is autism. And that's where it becomes really, really important to acquire the skills of listening to parents. So what do you want to listen to? It's really important because we say very simple things. We say that when parents have concerns about their children's development, please listen to them because they are valid. These are parents who, many of them, are probably spending their entire time hovering around their children, filming them, videoing them, looking at other kids, figuring out, okay, that person's kid is doing this. What about my kid? So sometimes we see that parents are way better developmental experts than even we are. And I do not mean that in a facetious way. I do acknowledge that parents really look and observe the children well. What's important for us as pediatricians, as general physicians, is to create those little windows when we ask parents, do you have any concerns about your child's development? And the parent will be able to tell you, well, those who don't, they're going to be telling, oh no, you know what she's doing really well. She's smart, she's picking this up. But then it gives you that little window to open that conversation about the child's development. Better yet, it's important to include a developmental screening tool. So there are tools like the Guide to Monitoring Child Development, which are 10-minute tools, which are meant to be done in the OPD. And if any of you are interested, you can please, reach out to me later and we can connect you to resources and reading material about such tools. But also, in addition to maybe asking parents, be alert for little things that parents drop in the conversation. And just random things that sound very abstract or casual, like, मेरा बच्चा तो अभी तक ध्यान नहीं देता है, अभी सुनता नहीं है मेरी बात. मैडम, वो अभी उतना बोल नहीं रहा है, कोई चिंता करने वाली बात तो नहीं है ना. टीचर्स बोलते हैं वो भी उतना खेलता नहीं है दूसरे बच्चों के साथ, या फिर वो बैठता ही नहीं है, बहुत चंचल है, अभी वो थोड़ा शाई है, दूसरे लोगों के साथ बात नहीं करता है, he doesn't talk to new people. या उसके मैडम ज्यादा सर ज्यादा दोस्त नहीं है. And this goes on and on. But these are little things that tell you that, okay, here are some worries, here are some concerns these parents are talking about. What does this mean? Can I look a little bit more in detail? And why is that important? Because, as I said, parental concerns about development are very common. And unlike the thought that, parents to bas bolte hi rehte hain, yes, of course, parents are worried. And if we ask them, about 50% of all parents will report some concerns on at least one area. And it is seen that I'm hearing a lot of static. Is anybody else getting that? Would people just, if there are others who have unmuted themselves, would you please mind muting your own mics? Okay. So we want to know that there are people, of those who had concerns, they did go out and seek help, but often almost 1/5 of them did not go out and seek help. They had these worries about the children, but didn't come out. And why do we say ask? Because often parents say that, we didn't know if our concern was okay or to ask or not. Maybe we thought, we were just being too worried. Or my husband thinks it's too, I'm too worried. It's not the right thing to ask. Often we hear, I don't know who to ask. I didn't know who to talk about my child's development to. Or I've asked in the past and they told me, you know what, you worry too much. This is nothing. This is all going to be fine. And these are kids, who I have seen, even today I was seeing in the SRCC OPD, a parent who was telling me, we've been worried from the time the child's been 1.5 years, and we've been told, don't worry, it's a boy, he will talk late. Then we went back and said, don't worry, this is a pandemic child, and this children may speak less. And then we went back at 2.6 and they said, well, you know what, it may be possible, so why don't you go and get help? But then wait for a little bit. And then finally, when they reached out for help at 3 years, this is a child who had autism. And as Anaita kept mentioning over and over again, there was a big amount of time that got lost when the child could have received help. And we could have worked on those neuronal connections much earlier. So talking to families for us as general physicians, as pediatricians, becomes really, really imperative. When we say, what do we want to talk to parents about? Right? So it's not just, okay, it's not just a general conversation. Often it does sound like a conversation, but we have to know that there are many kids who may or may not have minimal psychosocial risk factors at development, but there is a definite number or a proportion of kids who are not meeting developmental milestones. It's below optimal. And there may be other psychosocial risk factors present for such kids. And out of that, or in addition to that, there is a fraction or there's a proportion of kids who actually have significant disabilities. So what do some of these parents need who may or may not, whose children may or may not have a developmental disability, but who do have some concerns about one or the other aspect? They often need advice about behavior, right? They may have, okay, you know what, doctor, my child is a little clingy and school is about to start and I'm worried, okay, what can I tell? What can I do to help them? There are those kids who are development is below optimal, and often such parents will need training about how to provide a more enriched environment for the children. And who better than you all to provide them some of these strategies? But there are also those children who have a developmental disability. And these are children where just telling parents or reassuring them is definitely not enough. And they need special education. They may need speech therapy. They may need to see the physiotherapist or occupational therapist ASAP and without delay. Why is that important? Because it prevents those what we call as the door on the hand knob questions, right? So they've come for the vaccine or they've come for their cold, cough and fever, and they are on their way out and they ask you, by the way, doctor, जब हम इसको बुलाते हैं ना तो ये ध्यान नहीं देता है. I hope that's okay, right? सब बच्चे ऐसे करते हैं. और by the way, जब वो अभी भी ना 2 साल का हो गया है, वो उतना अच्छे से चलता नहीं है या चलते चलते गिर जाता है. And then you're like, the next patient isn't peeking in and you want to move on. And now suddenly this child or this family has brought up a concern and you think, oh my God, I really don't have the time to deal with this now. And that's why it is important to maybe proactively include these questions about, tell me about your child's development. They start seeing you as someone who's approachable, who's interested in their child and will be able to provide some direction. So let's look at some cases here. So I'm going to be waiting for some of you to reply on the chat. So I hope many of you will use the chat function as we move through the cases. So please think about this. Here's a 10-month-old little girl whose mother comes to you for her polio drops. And Daisy was delivered through a C-section and, her birth weight was around 1.2 kgs. So she was born a little early at around 34 weeks. She had exaggerated physiological jaundice. She had one episode of neonatal seizures. And, the reports that are in front of you suggest that she might have been hypoglycemic. But since then, she's been fairly okay. And now Daisy is happy. She goes da all the time. Mother bolti hai that, when she reaches out for toys that she sees, and then she puts them in her mouth and bangs them on the table and then throws them away. Okay. And you ask Daisy's mom, how is she doing in terms of her development? And a mother says that Daisy has started to sit, but she's a little wobbly. अच्छे से नहीं बैठती और उसको पकड़ के बिठाना पड़ता है. वो लेती तो है खिलौने. She's able to reach out for toys with one hand. But I haven't really, she's very scared. She doesn't let go of one hand. And so she can't hold on to both hands together. You ask, does she eat on her own or do you give her something to eat? And she says, yeah, she holds a biscuit, but then she'll use it. You hold it all like that and she mushes everything up. Now, so Daisy's mother is this really young mother. She's, this is her first kid. And she's learning to figure out how to manage a big family. But she's really tired and she finds it hard to play with Daisy. You know this family well. And when you bring this up, when you ask, okay, how do you work with Daisy? How do you, get her to talk and, support her development? You see that the mom's tearing up a bit, right? So at this point, I want to pause for 2 minutes and ask, do any of you have any concerns about this child's development at all? You can unmute yourself and speak up, or you can put it in the chat. So the question is, now that you've heard about Daisy, do you have concerns about any aspect of her development here? Come on, I want some brave voices to unmute themselves and speak up. Do we have someone? No? Still wait. Okay. Anyone who wants to talk about what you think might be something that's going on with the Daisy. So here's a 10-month-old, and mom says she's not walking very well, of course. She's not walking at all. She's not even sitting very well. She's doing a little bit of babbling. She seems to be going da. Does anybody have any concerns? आपको लगता है कि उसका डेवलपमेंट एक 10 महीने के बच्चे के जैसे हो रहा है? Is Dr. Usha unmuting herself to talk? Lagging behind. Yes, Dr. Desai. क्या बताना चाहेंगे कौन सी चीज में वो लैग बिहाइंड कर रही है, या आप उनको कोई डॉक्टर देसाई को कोई हेल्प करना चाहेंगे उनके साथ? ट्रांसफर ऑफ ऑब्जेक्ट्स comes early. Yes, absolutely, Dr. Furness. Well said. Anyone else? Dr. Trupti, will you kindly mute yourself, please? I think I'm getting a lot of static. Thank you. Anyone else? और कोई है जिसे लगता है कि डेजी में कुछ दिक्कतें हैं जिसके बारे में हमें सुनना है या कुछ जानना है? Not really. Okay. All right. So I think I got some really good answers. उसके बोलने के बारे में किसी को कोई चिंता है? एक 10 महीने के बच्चे से हम क्या एक्सपेक्ट कर सकते हैं? Delayed milestones. Yes, Dr. Vakil, absolutely. कौन से एरिया में delayed milestones है? Words. Yes, maybe words जैसे Dr. Yes, bisyllable words. Absolutely. Well said. Lots of good answers over there. Okay. So, thank you for all the answers. I think you are absolutely getting there. And what we are seeing is that this is a child who should be sitting, right? Of course, and one of you pointed out that she's not able to transfer. So yeah, there might be some fine motor delays. Language seems a little delayed. She just seems to be doing some random babbling here and nothing more than that. So this does look like a global developmental delay picture, right? And this is someone where if you are not feeling sure that, what do we do with this child? Maybe this is a child you want to ask them to see someone who, maybe it could be a neurologist, it could be a developmental pediatrician, somebody who might look at this child's development in more detail. But you also want to talk to the mother about what can you do? What kind of language-rich environment can you provide? What are some of the toys? How will you encourage this child to, maybe put a toy on a sofa and encourage this child to, be able to reach out for it? How do you support this child sitting so that the child doesn't fall back and is able to use both her hands to play with toys? And while you do that, you give them some simple strategies and you tell them, maybe come and see me back after a month or two and let's track how Daisy's doing. In which case, if the family doesn't, recognize what you're trying to tell them, you give them a little bit of time, you tell them what to observe, you tell them what to do to help the child, and then you're able to get them back so that you can talk to them, okay, this is now when we start therapy or, do more to help this child. Okay, thank you so much. Now, the next child is Akash. Now, Akash is a year-old. Now, the problem is that Akash, parents are telling you that, school has started, we have started sending him to this, not school, this little kind of child toddler kind of mother toddler kind of thing. But they are trying to think about leaving him there for a little bit because mom also has to start getting ready to go to work. And the problem is that he just cannot be away from his mother. And he cries a lot when he cannot see his mom. So mom tells you that Akash ne abhi bolna shuru kiya. He says single words like mama, baba, dudu. He's forever pointing to things. Usko ye chahiye to dikhata. He's pointing. He can bring small objects like the mobile phone on paper over to his parents when asked to, which means parents are so proud that, he understands everything. Usko hum jo bolte hai, wo laake deta hai. This little guy, he started walking when he was 11 months old, and he loves to feed himself. Wo khud ko chote murmure, chote Cheerios, cheeselings, ye sab khata hai baith ke. He has a lot of toys, and he loves to empty out his entire toy bin. Then he will pull a little toy truck. Mrs. Pandey, the mother, describes Akash as very happy and bubbly while she or her husband is around. But around other people, Akash is very shy. He hides his face in his mother's lap. He refuses to go to new people, at least in the beginning. And she took him also to that daycare, but he cried and refused to go. So now, mom says, you know what, I'm a very protective mother. I'm a first-time mother. So now they ask you, okay, is there a concern? What should I do? All right. Okay, so case 2. What do people think? Is there a concern? This is a simple yes or no question. Or you might want to talk about what is the concern here. What do you think is going on here? Would anybody want to add? The chat is all yours. Come on. Separation anxiety. Yes, bang on. Absolutely. So what do we even tell parents for separation anxiety? What are some things that we tell parents for separation anxiety? What would you tell parents? Would you tell them that, you know what, just leave the child there and go away. He's going to be fine. Would anybody like to add? What I'm sure you get such, parents in your OPDs. What would you say to such a parent? Would one of you want to unmute and just tell us? Sure, this is a very common scenario. क्या बोलते हैं आप parent को? Come on, let's make this interactive. Let's see, somebody has to tell us what is it that you tell parents. Okay. So I think to be able to explain separation anxiety to parents that, there are many children who can't figure out that if I can't no longer see mama, that doesn't mean that she's not going to come back. Yes, talk to the child, explain the process, gradually leave him in safe hands for short intervals. Absolutely. And talking to the child and also talking to the parent, reassuring her that the kid is going to be fine. Often separation anxiety is associated with a huge amount of anxiety in the parent herself, right? Will the child be okay? If the child is crying, does that mean that, he or she is going to be ill? Am I being a bad mother and leaving my child there? I need to go to work. Everybody is telling me that you shouldn't go to work so early. So often it's very interesting because it's not just the child, but it's also the caregivers who we need to work with. So being able to reassure the parent and the child that this, parent about the child, this is a phase. The child is learning to separate from you. The child is learning to be able to regulate himself or herself when they do not see, their constant object, their safe space. And that we can do it in small bits and pieces. You don't have to just leave the child one day in school and disappear. You can talk to the school, tell them that, is it okay if I come in for the first few days, or leave the child for maybe 15, 20 minutes, or even before school starts or the daycare starts, take the child around, make the child familiar with the place, introduce them to the teacher and show them, okay, listen, when you come here, there are all these fun toys and this is something that you're going to be seeing and playing with every day. So yes, thank you, Dr. Chopra. Thank you for your lovely answer. So a lot of it, as I said, is not just about, reassurance, but one more thing I do want to say, that we now know enough to know that separation, clingy behaviors, while most kids turn out fine, there could be some kids who actually have a high threshold for anxiety. And when we work with older children who come back to us with anxiety, children who are really struggling with anxiety around exams, anxiety around, being able to do well or not, anxiety about illnesses. If we go back in the developmental history, parents will tell us, you know what, they were always very clingy, or it took them a long time to learn to be able to go to school without their parents, or they cried much longer than other children when they went to school. So after a few visits, if you feel that the child is actually doing well, that's great for the child, for the family, for you. However, a fraction of such kids may need to be monitored for anxiety and other aspects of their life. Now, case 3, Anish is 2. He's walking, he's running, he can climb up to small heights, he can climb up stairs, he loves to scribble, he can pretend to drink out of a cup, and he pretends to bring chai for mama. However, Mrs. Mehta says, but he does so much, but he doesn't say a lot. He has about 4 words. Remember, he's 2, he has about 4 words. And when you ask Mrs. Mehta, tell me, Anish, aur kisi tarah aapko batata hai what else he needs? So Anish will pull her sleeve, point to the kitchen, and the mom says, "Oh, mama bolta hai pani ke liye, or cookies ke liye, ya biscuits liye B bolta hai." And mother says that uska ho jata, he's done. He'll look at her with a nice, cute smile, make a gesture with his hand to show that there's no more, and says fish for finish. And that's how Anish is done. And now she asks you, I have this girl, if I have an older daughter, and she started speaking when she was 10. And I've been told that boys speak late. And I'm thinking, maybe I'm a working mother and I don't give him enough time. So should I even worry? Is there anything to worry about? So what do you think? Is there anything that mom needs to do, or it's just okay? And maybe it's just because boys speak late and she's a working mom. What will you tell the mom? Does mom need to do anything? I'm hoping that some of you are frantically typing in the chat. Okay, I get an answer. Communication problem. Okay. All right, Dr. Bhatt, thank you. So there's something delayed about his communication. Can somebody tell me how many words approximately should a 2-year-old have? 2 साल के बच्चे को लगभग कितने शब्द होने चाहिए? हमको कैसे पता चलेगा? Dr. Chaudhary is saying definitely delayed expressive speech. Yes, needs remedial measures. So how will we say कि it's definitely delayed? हमारे पास क्या, what is our comparison? What sentence? Okay, 2-year-olds speak sentences. Well, some 2-year-olds do nowadays. Many don't. So usually just very simple OPD thing to remember is by 1-year-old children speak single words. By 2-year-olds children have started joining to say 2-word phrases. Pani do, gumi chalo, mama de, papa nahi. So joining 2 words. By 3 years, children have started to use at least 3-word phrases, right? So this is what they're able to say. Similarly, in what they're able to understand, they're able to understand simple 1-step instructions by the 1st year. Ye de do, utha do, bhar do, dal do, pick up, close, things like that. By 2 years, they should be they should be able to understand 2-step instructions. Pick this up and put it there, or bring this and give it to her. So these kind of things. So when we hear that a child is 2 years old and saying only 4 words, well, there is a significant delay, right? So this is what probably a 1-year-old should be saying. But on the other hand, we are hearing also from mom that this child uses a lot of gestures. He's very happy to play. He's got lots of pretend play. He's listening. So I'm not thinking autism so much, but I'm definitely thinking of language delays. So some of you said that, language delays. And why is it important? Is because once again, many children, or 50% of children with just language delays, not autism, will go on and acquire language. But this is a group that is very high risk for later learning difficulties, right? Because language is the basis for academic learning. And this is a group. So if you see a child with learning delays or learning difficulties, agar aap kabhi pooch ke dekho, if you ask them back, many of them, not necessarily all of them, the parents will tell you, हाँ ये late बोला था, या इसने late, language pick up किया था, या फिर पहले इतना बोलता नहीं था, Okay. So once again, we are talking about what do we tell the parents? So this is the second band, the band where we said that parents need some simple strategies because it is below optimal. So we want to talk to them about what can this mother do? वो पूछेगी मैं क्या कर सकती हूँ मैडम आप या सर आप बताइए. So you can say जब उसको कुछ चाहिए तो say the word for them. They want biscuit, say biscuit. They want to go out, then you can say go out. They want to wear shoes. They say, oh, shoes? You want to wear shoes? Read books together, play interactive games together कि हम doctor खेल रहे हैं या फिर we are pretending to make something together, because when we do pretend play with children, we tend to use a lot of language. So these are children who benefit from this environment, especially because they love being around people. So these are some things that you can definitely tell them. And then finally, this is our last case. So Tanmay is 3. Now he lives in an orphanage, jahan pe shayad aap, you provide services or you go and see the kids or something. And he's very active. So the caregivers tell you कि बहुत active है, बहुत ज़्यादा. Uधर चढ़ता है, he climbs up, climbs down, गिर जाता है कभी-कभी, पर फिर भी उसको लगती नहीं है. खुद को खाना भी खा लेता है. वो बहुत smart है, हाँ. He can scribble with a pencil. अभी थोड़ा toilet train भी हो गया है. And what you say, what do you mean? So when he needs to go to the toilet, he can even pull his pants down and go. But when somebody asks Tanmay a question, he mostly ignores them. He can understand simple instructions like put this on या give the glass to him, तो ये समझ लेता है. उसको बाकी बच्चों के जैसे भागना अच्छा लगता है. But then when you ask the caregiver, this is, हाँ, but you know what? वो बाकी बच्चों के साथ नहीं भागता है, उनके साथ नहीं खेलता है. He runs around other children. And the caregiver has not noticed him play with the children. ऐसे उसको कुछ ना, उसको खेल में, खिलौनों में interest ही नहीं है, उसको बस भागने दो. He doesn't play with toys, doesn't engage in pretend games. And the other thing is, the caregivers are changing all the time. It's like how it is probably in an orphanage, and you talk to one caregiver one day and the next day somebody else is talking. So now what are you thinking about? Okay. Attention deficit, maybe hyperactive. Yeah. Yes. There seems to be attention deficit. There seems to be hyperactive. Anything else? Do you notice anything else? Remember I told you that you have to hear for those little things that parents or caregivers throw at you. They have thrown you some more nuggets if you can listen well. Something else is here. He's not interactive. Yes, he's not interactive. And that's really important because you know what? The other kids are. His peers at the orphanage who are being brought up by the similar set of changing caregivers, they seem to be more interactive. So he's not interactive. उसको कही गई बात वो अनसुना करता है. Sometimes you may hear words like moody. He's moody. वो सुनता नहीं है. वो जब चाहे जब उसको सुनना होता है तभी सुनता है. थोड़ा बहुत समझ लेता है, but doesn't. So yes, absolutely. So these are some things, and especially when you hear things like he is not interested in toys or he's not interested in other children. Now those are real red flags. So this is not what you hear from a child who only has ADHD. And why is that important? Because actually ADHD is the most commonly given diagnosis to young autistic children. And unfortunately, their autism diagnosis gets missed. So we are noting that there are language delays. We know that play is different, but we also know that there are social difficulties, right? And this kid does seem to be very high risk for an autism diagnosis. So what do you tell the caregivers, right? You tell them, "वो आपकी तरफ ध्यान नहीं देता है ना, you have to get to their level, get to his level. Maybe he's not looking at you. So maybe go down, go down on the floor with him." Use single words. So often we end up telling parents, "बहुत बोलो, बहुत सारा बोलो." But the reverse is true. Use less words when you're talking to children who are not speaking. Use single words, use short phrases. So those words can register in these children's brains. When you speak long sentences, वो कभी-कभी register नहीं करता है. Create opportunities. Can we play peekaboo, छुपन छुपाई, एक बॉल फेंकना लेना, जिसमें interactive play है, जिसमें बच्चे को जरूरत पड़ती है और किसी की तरफ ध्यान देने की. If possible, to talk about ये चीजें हमको कंसिस्टेंटली करनी है, और ये करने के लिए केयर गिवर का थोड़ा कंसिस्टेंट होना जरूरी है. It may not be this orphanage. It can be another child who's now, sometimes playing with the grandmother, sometimes with somebody else, and nobody kind of knows who's this child interacting with. So having one or two consistent caregivers really makes a difference when a child is undergoing developmental delays. And yes, this is the kind of kid you definitely want to refer. So I know that I'm coming to the end of my time. So I want to leave you with some very simple take-home messages. A, proactively ask parents about the child's development. It's very likely they may not bring it up, right? If possible, use a screening tool. Bring in small ways जिससे आप आपके वो बच्चे के लर्निंग एनवायरनमेंट के बारे में बात कर सके. क्या बुक्स है, कौन से खिलौने हैं, क्या चीजें हैं जो आप उसके रोजमर्रा की जिंदगी में कर सकते हैं. उसके नहाते समय वो उसको अभी कपड़े पहन के घूमने जाना है, तो क्या हम उसको बोल सकते हैं शूज लेके आओ, तुम मेरा पर्स ला दो, तुम्हारी वो बैग कहाँ रखी लेके आओ. So these are little ways in which you can incorporate these activities in the child's daily routine. And of course, encouraging parents to get help for developmental concerns early rather than wait and watch. So that's what I have for you today. So if there are any questions or comments, feel free to leave them in the chat. Thank you so much for your positive comment, Dr. Chaudhary. Really appreciate it. And thank you to everyone who stayed on. So over to the facilitator from the Narayana Health side. If we could, is it okay if we wrap up now? Okay. Well, thank you everyone, and hope you have a lovely good evening. Bye-bye.